Good morning. Good morning. Good morning. Thank you for that energy. We need it. All right, everyone. If you could take your seats, we'll go ahead and get started here. All right. Thank you all for joining us bright and early again for our day 2 of our Global Adolescent Health Economic Strengthening Conference and CHILD-GRF final meeting. I know most of you, but I'll go ahead and introduce myself for the people on Zoom. My name is Chelsea Han Sheridan, and I am proud to be the Training Programs Manager here at iChad. I'm very excited to see our CHILD-GRF trainees. It's been a while and get to hear from them. Yeah, woo. I will be joined today as co-MC with Mr. Timothy Apobo, so he will be joining us a little later. Just a couple of announcements for those that are new or joining us today. Housekeeping. Restrooms for women are just outside these doors and to the left. Restrooms for men and women are also downstairs all the way to the end of the hall on the left. If you get lost, just ask any one of us, and we're also happy to direct you. And for those that have had a chance to look at our schedule for today, we do have a brief update. Unfortunately, Mr. Isaac Makua from Uganda National Council of Science and Technology wasn't able to join us due to traveling logistics. And so we will be moving lunch to 1 p.m. rather than having a working lunch so that the CHILD-GRF speaker series panel will not coincide with lunch. So we'll go ahead and do the speaker series, and then we'll have a period just to enjoy and relax for lunchtime. So that's the brief update to today's schedule. Other than that, yes. We are also very fortunate that one of our CHILD-GRF trainees, Dr. Damali, was able to arrive last night and will be doing her final presentation. At 11:30. So we'll add her in ahead of our speaker series. So we'll get to hear from all of our cohort 3 trainees that are traveling. And with that, I think that's all the housekeeping notes. If there's others, I'll bring them up. But I'm very excited to welcome one of our iChad co-directors, Dr. Ozge Sensoy Bahar, who will be giving us opening remarks and introducing our first speaker, Dr. Mark Huffman. Thank you, Dr. Ozge.
Good morning, everyone. My job today is to welcome you to day 2. We had a really exciting day yesterday. We tried to schedule for lunar eclipse today. It just didn't work out. Maybe next time. We have a very exciting day waiting for us. We have different workshops and really exciting speakers. Like Chelsea mentioned, we're going to hear more about our CHILD-GRF trainees' work. So it's going to be a packed and very exciting day. So thank you very much for being here. And then I will start the day by introducing Dr. Mark Huffman. Dr. Huffman is a practicing cardiologist, researcher, and educator with more than a decade of experience in global cardiovascular epidemiology, clinical trials, implementation research, and health policy research and training. His research spans the spectrum of disease prevention. He's interested in improving global cardiovascular health and healthcare in low and middle income countries through the implementation of evidence-based interventions and policies, and in bringing lessons learned back to the United States. And he is an excellent collaborator and supporter of iChad.
Good morning, everybody, and thank you, Ozge, for that kind introduction, and thanks, Fred, for the invitation to participate. How exciting it is to be with you today. I mean, to learn about some of the work you're doing. I'm excited. I know a little bit, but I'm excited to participate today. And I'm going to share a few things about the Global Health Center at WashU, and then a little bit about my own research. We're very fortunate here at WashU that we got a lot of activity that you wouldn't necessarily think here in the heartland, that there's so much global health expertise. And so I think, here at iChat, I believe the Honorable Minister met with Professor Gary Weil, for example, who focuses on neglected and tropical diseases. And at the Global Health Center, some of the work that we do is aligned really with that and hopefully complements that, so that just like at your home institutions, the whole of your institution is greater than the sum of its parts. It's really by working together that you aim and hope to achieve some of your major goals. Okay, so the mission of the Global Health Center is to improve global health through transdisciplinary programs and partnerships across WashU and around the world. And that transdisciplinarity is really around asking the questions together. It's not just as a physician, as a cardiologist saying that these are the key issues, but when we come together across university departments, for example, and then with university partners outside of the academy, that allows us to really ask good questions. And I think of all of you who are researchers, you've probably spent a lot of time trying to think about what's that really important question that if I were successful, that would have a major impact on the field or practice or in public health. And so if we think about for NIH grants, so raise your hand if you are applying for NIH grants sometime this year. Okay, so many of you are thinking about the significance section, right? So that significance is not that this is a big problem. The significance is if you're successful in your research, what will you have? And so that's when we're thinking about impact. I want you to think at the end of the grant period, not just at the beginning of it. And our strategic vision is to develop a transformative and impactful center through research. And we focus on this local to global, where we're thinking about what's happening here in St. Louis that's relevant to other contexts, but similarly, what is happening around the world that we can bring to people, populations, patients, from my perspective, here in St. Louis, because there's a lot of shared issues around my field, heart health, but similarly around economic empowerment, mental health, child health, and so on. So that's really what we're trying to do within the Global Health Center. We are aligned. I believe you heard a little bit about Here and Next yesterday. So this is exciting because Washington University is a relatively distributed university where a lot of the decisions and influence happens at the unit level, maybe at the department or the school, but Provost Beverly Wendland, who was here yesterday, and Vice Provost Mary McKay, are really trying to organize the entire university around Here and Next. And this is how we do these bigger things together. And so some of the key aspects, the Office of Public Health, for example, is one of the co-sponsors of this meeting. And public health, I mean, this is exciting. We're going to be creating a new School of Public Health on the left-hand panel. And on the right-hand panel, you see global presence. And this is amazing that people come from around the world to St. Louis. I'm born and raised here in St. Louis. So it's exciting to get to serve as host. And as many of you who've traveled around, when you go to a place and people give you that warm embrace as the guest, you say, well, those are nice people. I like those people and I want to work with those people. And so that's what we at WashU, I think, need to not only be good hosts, but getting out into the world and contributing. Kind of these principles of mobilizing research, education, and patient care to establish WashU and St. Louis as a global hub for transformative solutions to the deepest societal challenges. We've been busy over the past year. We hired an assistant director of the Global Health Center, Dr. Ashley Barden, who has a PhD from the University of Washington. For those on campus who may have participated, we have a monthly early stage investigator seminar program. We're having a kind of a social hour next month. So we're really invested in making sure people who are early in their careers, maybe similar to some of you in the audience, are getting that support that you need to make that transition from maybe from your PhD to your postdoc, or maybe from your postdoc to a faculty position, or some other professional position outside of the academic context. We host an annual summer research program. There are two tracks. One's public and global health, and the other is called Radiance, that focuses on cardiovascular disease and hematology. These are for students who are underrepresented in research and medicine, and they're combined with the kind of larger summer research program. So that'll kick off in June. We have a Global Health Annual Conference. So in 2023, we had programming both on this campus as well as the medical campus. We co-sponsored a Food Futures Initiative earlier in 2024. We provide seed funding, which we did in collaboration with the McDonnell Scholars Academy in 2023. We have in the fall Global Health Week, which is really trying to get global health programming across different units across campus. Just yesterday, Professor Daniel Mama talked about his research at our seminar series on psychosis research in Kenya in collaboration with the University of Nairobi. We do have a Global Health Student Advisory Committee that gives us advice of what his students really want. I met with them on Friday just to try and understand how do we help not just the faculty, but also the students. And then Fred and I are charged with the Office of the Provost to help create a global research scholars network. And so some of that is this type of programming of bringing people together, getting to hear about what people are doing, creating new research partnerships, but also just that trust that we need to build by being in the room together, being on Zoom together, maybe writing papers and really putting pen to paper and work. So we're eager to continue to build that and understand what are our strengths here at WashU, how do we build on them, and what are the areas for key growth. Later this spring, hopefully we're trying to figure out if we can get it scheduled, or maybe it'll be in the fall. We're going to host a Global Research Operations Forum. This comes from Professor Gary Wiles' kind of idea, and Betsy Abente, who has worked in his group and now works with Thomas Odeni. Some of us face these challenges of like, how do we work internationally? And these are all questions that you or your teams have probably dealt with on some level. And many of you have expertise that would be great for other people, maybe less experienced, to learn from. And there can be some potentially influence on policies at the university level, things that we can make this easier so that the flow of research and ideas just, flows a little more easily. So hopefully it's trying to provide service as the Global Health Center to the university. What do our stakeholders want? We hear loud and clear, people want better operations. This is some of our early stage investigators, just to kind of put faces to the idea. And they range from people in psychiatry and Lindsay to Anuba in cardiology, Layao in allergy immunology. And so this is a group that started out just kind of a handful and has been growing because I think you're in this room because you want community, and people are, you're trying to find who can I spend time with and learn from and bounce ideas off of. And we are lucky because we got fantastic early stage investigators, many of them NIH funded, doing really high impact work. So we know we got to support these junior people because they're going to replace me and, Fred and senior people in the not too distant future. Training is a really important part of what the Global Health Center does. And I'd just like to highlight one program in addition to Radiance and the summer research program known as PRIDE. This is in its kind of third cycle. Victor Davila Rahman, who's the director of the Global Health Center, is the contact PI, and the other PIs are Lisa de las Fuentes and DC Rao. This is a program to increase diversity in research funded by the National Heart, Lung, and Blood Institute. Global Health and Dissemination and Implementation Science are now part of this program. So we're getting scholars, these are usually junior faculty, who are getting kind of cohort level support, similar to how your program is here. So some of the things that we're trying to do, ongoing activities, are strengthening our collaborative work across schools. Fred knows that I'm on this campus at least once a week. I'm trying to make sure that, we're listening to what people need. Just because I sit on the medical school, the exciting thing about being at WashU is that we've got these amazing other schools besides the medical school. And if I don't, come to the other schools, it's not everybody's going to make the trip across our beautiful Forest Park. We're going to continue our training and capacity building. We like to write grants. That's like what we do. And I would say Juliet Ilwalunmore is going to speak with you later today. She's like, I'm a grant writer. And, so I think that's a core function for our job and the people who work with us. And really just trying to continue to increase our local, national, and global impact. This upcoming year, we are looking to systematically demonstrate our impact using something known as the Translational Science Benefits Model. Raise your hand if you've heard of the TSBM. Great, I'm so glad because I get to tell you a little bit about it. So the Institute for Clinical and Translational Sciences here at Washington University has created a framework for you to say, like, well, what have I really done? So I've written some papers, maybe I've even gotten some more grants, but like, what's the real impact, right? And there are research impact frameworks that are out there. This is one that's being used now more widely throughout the United States that looks at impact at things like the clinical level or the community level, the economic level, which is really relevant to this group. And there's impact profiles. Doug Luke, who's in this school at the Brown School, has really helped to create this. And it's a way for you to showcase your work beyond just, hey, here's what the p-value looks like. But here are the relationships that we developed, maybe as a group, that we worked really hard at. So some of the work we've been trying to do, I'll explain in Nigeria. I'll use one example of that, of the TSBM. And then we're trying to figure out what is our governance model. We are sponsored by the Department of Medicine and the Institute for Public Health. And you've perhaps heard about a new school of public health here at Washington University. And I think many of us are trying to figure out, well, what's that going to look like? There's a new dean who's going to be hired soon. So a lot of excitement on campus. So that's the Global Health Center, in which I'm the co-director and wanted to tell you about. Next, I'm going to shift gears to talk a little bit about cardiovascular health and disease. So cardiovascular disease causes 1 out of every 3 deaths around the world. 1 out of every 3 deaths. It's incredibly common. In the United States, 2 out of every 3 men and 1 out of every 2 women will experience a cardiovascular disease event in their life. Whoa. So like, look left, look right, one of these things, like, it's common. And so people who have ideal cardiovascular health, and these are kind of some of these common sense things: don't use tobacco, eat a healthful diet, be physically active, keep a healthy weight, have a healthy blood pressure, have a healthy cholesterol, have a healthy glucose, and get enough sleep. Those people have substantial reductions in their cardiovascular disease burden. So they live longer, they live healthier, they have better quality of life. It's lower overall costs of the health system, including in the last year of life. But it's incredibly rare, and it's very difficult for people to be able to develop cardiovascular health and maintain it and sustain it throughout their lives, because the environments in which we live aren't always the healthiest. So that's been one of the key kind of North Stars for my research program, is to try and think about, how do we improve cardiovascular health? At the same time, people are having heart attacks and strokes all day long, and we need to have health systems that can respond to them. So for my research program, it's trying to think about working across this whole spectrum of cardiovascular disease prevention. So tertiary prevention is someone who's having a heart attack. And so I led the ACS-QUIC, or Acute Coronary Syndrome Quality Improvement in Kerala trial. Kerala is in South India. That was funded by the National Heart, Lung, and Blood Institute. And this is the largest cardiovascular randomized trial conducted in India, with more than 21,000 patients. And we showed that by implementing best practices in a structured way, using a rigorous step wedge cluster randomized trial design, that we can improve the quality of care, the delivery of life-saving medicines. But in Kerala, things are actually, the care is quite good. The survival for heart attacks in South India is similar to what it is here in St. Louis. So by accounting for these trends, health systems they're moving whether or not we're studying them or not, right? And so use your rigorous study design so you know clearly what causes what. Because if we used a conventional pre-post design, we would have said, we did it, we reduced mortality. And it actually wasn't the case. So that rigor has been something that I found to be useful, sometimes to show when things work, but also to show when maybe it doesn't. Second, the hypertension treatment in Nigeria program. This is the second largest hypertension control program in Africa. We've recruited, again, more than 21,000 patients across 60 public primary care facilities in Abuja, in the Federal Capital Territory. We started with a hypertension control rate about 20–25% and have increased it to more than 50% for almost 2 years. The translational science benefits model that I was talking about earlier, one of the community impacts is that the government has said, well, we're starting to expand community health insurance. If you give us the names of the participants, we'll give them all insurance. We're like, are you kidding me? Because payment for medications is one of these key barriers to be able to sustain blood pressure lowering treatment for a long time. So for us, we're really excited we just submitted a renewal to do a national scale up. And this is using the WHO Hearts technical package. So for those of you who touch cardiovascular disease at all, this is kind of the package for integrating cardiovascular services in primary care. And we've done a real deep dissemination implementation dive on what's the taxonomy for all these things? And we think that our dose is really what matters. We deliver a greater dose of training, support, and we include a financial strategy. We've created a drug revolving fund, much like is done in other contexts for other conditions, to be able to reduce the out-of-pocket costs for patients to be able to afford their blood pressure lowering medications. Third example would be something in the US. So I was at Northwestern University for 15 years until coming to WashU about 2 years ago. And the idea of combination therapy, it's not rocket science. It's like a multivitamin or HIV therapy or TB therapy, putting multiple drugs into a single pill. We cardiologists, though, like to tinker. We think like a little bit of this blood pressure, a little bit of this cholesterol is going to make the difference. It probably isn't if we can actually just get pills to people. Most people who've had a heart attack and stroke around the world take 0 medicines, not even an aspirin, to be able to prevent another heart attack and stroke, let alone people who've never had a heart attack and stroke. It's even lower. So we asked the math question. This is a math question. Is 4/4 greater than 1? That was the trial question. If we take quarter doses of medicines, very low doses of blood pressure lowering medicines, but combine them, is that going to be more effective than a single medicine at a standard dose? And in fact, it was by about 5 millimeters mercury on the top and about 5 millimeters on the bottom. And we tested this in a federally qualified health center network in Chicago. So these are for people with no insurance or very limited insurance, and it could be immigrants or refugees. And so this idea of combination therapy has often been said, well, it's good for people, quote, over there. Like, no, it's good for Chicago. It's like, this is a problem the world over of like remembering to take a pill a day. And then maybe the last one I'll give an example is the Nigeria sodium study. So this is thinking about sodium policy evaluation. So Nigeria has these very assertive policies that they seek to implement to regulate the amount of sodium that's in packaged foods, for example. But like, how well is that working? So we do retail surveys to understand what's in the food supply, how much sodium's in that. We actually are starting to do analysis of street and hawker foods, of like actually taking it, blending it up, and testing it using a salt meter. We also do stakeholder interviews to like, does anybody know about these policies? Do people like these policies? Everyone's like, nobody even knows about this. People are kind of indifferent. So you're like, okay, well then, where, if the policies are enacted, what effects would that necessarily have? So we've done a dietary sources of sodium in Nigeria where we're asking people extremely detailed, like 4 24-hour dietary recalls, doing 24-hour urines to really understand where these sources of sodium come from. And it's not a surprise to us, but to have the data, to about 25% of sodium comes from bouillon alone. And bouillon, when we go to the marketplace, there's a 10-fold variation in the amount of sodium in bouillon. So you're trying to think like, okay, if you're going to make sodium regulation, you can try and do every single product that's in the marketplace. That's going to be politically difficult. You're going to have to play a lot of political chips. Or you could restrict it to a few high sodium products or categories of products. So I'll be in Nigeria in a couple of weeks, and those are the discussions that we're having. And we're the technical people. We provide like the modeling and the data on the epidemiology, but food is obviously very social and political. Like it's a decision for the people and for the government, not obviously for us as researchers. We have additional NIH-funded projects related to maternal and cardiovascular health, research training, and then more advanced dissemination implementation science work. Final thing is around, because this is about costs. Costs is very important related to cardiovascular health. People with lower socioeconomic position bear a disproportionate burden of cardiovascular disease. It's not a disease of the rich. And then individuals who have things like heart attacks and strokes, that's an economic cost as well. So it kind of creates this vicious cycle. So we asked more than 2,000 respondents in Kerala if they've had a heart attack, show us all the different costs in the hospital on this panel. You can see the categories on the x-axis after the hospital. This was for a private hospital. And what's the self-reported expense using international dollars? And so treatment, really coronary stents are really the most expensive treatment for people. Out-of-pocket costs is nearly $500 per event. More than half of individuals experience catastrophic health spending, meaning more than 40% of their non-subsistence income is spent on health, and 8% had distress financing, meaning they had to sell assets or borrow money to be able to cover their medical costs. So it's a big problem. I've got amazing mentees. Anuba is a faculty in cardiology, Zainab, also a faculty in cardiology, who do different work in heart failure and maternal cardiovascular health. Kavitha Singh is based at the Center for Chronic Disease Control and Public Health Foundation of India. She has a K43. So it's just to get a great team of people. Anuba recently had a paper published in Nature Medicine on this idea of combination therapy. And the policy angle for this is that we actually successfully submitted an application that was accepted to include polypills to the World Health Organization's model list of essential medicines. So trying to influence policy about what medicines are promoted. And our hope is that this will increase the business case and de-risk polypills to expand them in the marketplace. I also helped create the World Heart Federation's Emerging Leaders Program. This has trained more than 200 people from more than 50 countries in implementation research, health systems, and health policy over the past decade. So it's trying to work within these professional organizations in your field to try and, just like you're here, to be part of these networks. That's where I think the real magic happens. So I'd like to thank you for your time and attention, and again, for the invitation to have a chance to share a little bit about the Global Health Center and a little bit about me, and think you can improve your cardiovascular health. And I'm happy to talk to you after. All right, thanks.
I feel like we should all jog in place or something after that, but yeah. All right. Thank you so much, Dr. Huffman. That was really a wonderful way to start us off this morning. Our next, we have a couple of options. So we're going to have two breakout sessions that you can choose from. Our first breakout session will be Implementation Science Frameworks with Dr. Byron Powell, and that will be here in this room. We're also offering a missing data imputation workshop with Dr. Guo, and that will be in Goldfarb, and we will have one of our team members to walk you over to that room. So please make your decisions. One brief announcement before you head out: we will take a break at 10 a.m., right at 10 until 10:15 for a coffee break. So if you're coming from the other session, please come back here no later than like 10:12, so we can get started at 10:15. But all right, we will go ahead. Oh, okay, sure.
Or not. I can go sit back down. Right. Yeah. Thanks. Yeah, we do have economists on our team thinking largely around community insurance and trying to think about what's included in some of those insurance packages. I would agree that economic empowerment's, an exciting idea. Like, we've talked about this and just the general work, because it offers the other side of the equation, right? It's not just like trying to extract, but trying to create. And so, yeah, I probably haven't given it enough thought to think about how can economic strengthening improve the ability to care for oneself, healthy eating, access to medicines. I do think about Professor Michelle Albert, who's at the University of California, San Francisco. She's the past president of the American Heart Association, does have some research trying to think about empowerment for people to address their social needs. And so she has a randomized trial that's looking at providing just economic support, but also as an alternative, the comparator is trying to provide legal support, for example. So trying to understand what are the barriers that people really face in their day-to-day. Like, some people, it's around, their landlord is looking to, squeeze them on the rent or evict them, or something that's a really major social stressor to them. And money's sort of part of it, but it's sometimes like a legal arrangement that they actually need the help with. So yeah, lots of good ideas. That's why I'm glad I'm here. Please, yes. Yes.
Really interesting concept. I'd love to know two questions.
Yep.
How you measured distress financing, and whether you measured how individuals or families respond to that.
Say the end of the last question again. How they
respond to
yeah.
distress financing.
Sure. So distress finance, this was something that was developed in collaboration with the World Bank to think about ways in which people respond to financial shocks. And so catastrophic health spending is kind of that just, proportion of income. And then the distress financing is trying to capture the buffering mechanisms that people do. So it's a survey of asking people, did you borrow money? Did you sell, gold? Like in South India, gold is, people will have gold in their, jewelry and those sorts of things. Did you sell livestock? Was it from if you borrowed money, was it from a relative or a bank, and those sorts of things. In terms of their responsiveness, it's often, we did cross-sectional data, so we weren't tracking people over time, but the literature suggests that people are making decisions on what to restrict. And so they're choosing not to potentially buy, maybe healthier food or pay for medicines just because there's only so much. There's debate around the threshold for catastrophic health spending. I mean, some 30, some 50, but I mean, $500 for that community is a lot of money and a big shock, particularly when you have more heart attacks in India than any other country in the world. So the tension of like, well, what is the regulatory response for, well, go to the government hospital and you'll receive care there at a lower cost, but you still have coronary stent costs. Then Prime Minister Modi had a policy of the sort of the slogan is make in India, like made in, and make in India. Part of that was we have a country with coronary stent manufacturing. So there was a price cap on coronary stents that basically meant that international stents were not going to be really feasibly, financially viable. And so there's interesting how like in a very specific area, interventional cardiology, which probably people never think about this, there are these like national policies that influence the care that people receive that influences their out-of-pocket expenses. And it does seem to have reduced the out-of-pocket expenses. The cardiologists were grumbling. They weren't happy like to be restricted in what they had, but the market has kind of shaken out in that, and it's maybe worked as better than people had first feared. But I find it fascinating on like these things weave very quickly in people's lives because it is so prevalent that people experience this. And then you think about the different forms of cardiovascular disease. So if someone has a heart attack, most of those people recover. Some may have angina or heart-related chest pain or pressure with activity, but their quality of life can often resume pretty close to where they were before. Contrast that with a disabling stroke, where someone is not able to work. They need home care because of their disability. So that is very disruptive to their economic stability, livelihood, those sorts of things. So yeah, thanks.
Thank you very much for your interesting talk. I see you're doing a lot of work in cardiology in Africa.
Yeah.
Do you have similar work that you're doing, but in psychiatry or mental health, still in Africa or around the world? And how does someone get to actively participate in that work? See what you're doing and then maybe want to join and do the work with you. Thank you.
Yeah, thank you. I do work with psychologists and psychiatrists, some in the US and some internationally, and it's often kind of at the intersection of comorbid conditions. So you think people with one condition are often susceptible to developing another condition. So for individuals who might have an incident mental health condition, they may be more likely, for example, to develop coronary disease. And vice versa, people who experience a cardiovascular disease event, such as a heart attack, about 20% of them become depressed because of that. So that adjustment disorder related to that. So that's often a way in which we will work with people because we're kind of starting from our like, well, here's our kind of research operation. So working something from the side, but it could be the opposite too. If you have a strong mental health unit, you might end up doing a small cardiovascular component. It's just probably, what's your prior, what's your starting from. Thank you so much. Thanks.
All right. Thank you so much, Dr. Huffman, for those additional questions. That was great. We have the options listed here on the slide. For those joining us online, I believe the Zoom link for the missing data imputation workshop will be dropped or has been dropped in the chat already. But for those that would like to remain for Dr. Byron's, you can just remain here. For those that would like to head to the missing data imputation workshop, our colleague Salaiti is going to walk you over. So please make your decisions. We'll see you back at 10 o'clock. Thank you. All right, everybody, if you can take your seats, we're actually not going to take a break until 10. So if you can just take your seats, we'll welcome Dr. Powell for the Implementation Science Frameworks Workshop. Thank you, Dr. Powell.
Thank you.
So thank you so much for the opportunity to be here and welcome everyone. I'm going to spend a bit of time this morning talking about implementation science frameworks, and I realize that maybe some of you are already very deep into the area of implementation science and doing a lot of this work. Some of you might be, just beginning to be interested in implementation science, and so hopefully this is pitched at the right level. It might be too basic for some, and maybe we'll move too fast for others, but we'll try to strike a right balance. One of the things that I do, I always have too many slides forgive me. But I've included a lot of references, including PubMed IDs and things like that for you to take a look at things if any of this moves too quickly. So I believe the slides are in the chat for those who are on Zoom, and will be emailed to folks who are not. I'm going to give a very, 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 very brief introduction to implementation science, just sort of framing the area, and then provide primarily an introduction and overview of implementation science frameworks. And so many of these are sort of broad frameworks that cover the key constructs in the field. I'm not going to talk that much about theories that really connect these key constructs and are maybe a bit more explanatory, but that's certainly an important direction that the field is moving in. And so hopefully I can at least allude to that at various points. And then if we have time, I'll give a quick applied example just of how we've applied some of these basic frameworks in our work, and hopefully have time for discussion. If not, I'll be around today, and if those of you who are sticking around longer, happy to schedule a time to chat at another point. I also included a ton of bonus resources related to research reporting and implementation science. This might be sort of beyond the talk today, but had a bunch of slides on that hopefully will be helpful to you as you embark on this area. So just to kick off with, we often talk about there's a growing body of evidence for a lot of different types of interventions, right? And this might look different depending upon the type of work that you do. These aren't perfect categories, but sometimes referred to the 7 Ps: programs, practices, principles, procedures, products, pills, and policies. But the idea is that we have a growing body of evidence for things that we would like to see implemented in quote unquote real world settings, in community settings. We'd like to see them implemented, hopefully sustained and scaled up. But oftentimes, despite this moniker that we would like to move sort of from bench to bedside, from basic science to patient or population benefit, we often move from bench to bookshelf. That things sort of, evidence-based practices languish on the shelf. They're not implemented. If they are implemented, they may be implemented poorly, not with fidelity, so that they don't necessarily retain their effectiveness and have the impact we'd like to see. So implementation science has really emerged to address this gap, right, between what we know and what we do. And it's been defined various ways. This is from the inaugural editorial in Implementation Science, which defined the field as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. And they note that it includes the study of influences on professional and organizational behavior. I guess I will note here, they don't necessarily include patient behavior in this, but I think that the field has expanded very much to cover that as well. I think a couple things to note about this definition. One, note the piece about methods to promote the systematic uptake of evidence-based practices. So this is essentially the implementation strategies or the interventions that we use to actually get effective practices into routine care. And then this piece about influences on professional and organizational behavior, and again, one could argue patient behavior, really is focusing on the types of determinants or barriers and facilitators that either get in the way or facilitate the move of effective practices into routine care. So I'm going to talk about a number of potential frameworks that can help us to understand these elements further. And first of all, why should we even use frameworks? Why use theories and frameworks in the field? How many of you just really love theories and frameworks? Show of hands. Mark loves them. He's excited. Ryan, thank you. Niall, I mean, we have a few, but not many. But so I'll play to both sides throughout this presentation. Trust me. One reason why we should use frameworks potentially is that not doing so is really inefficient. It doesn't necessarily build on what we know in the field, right? It sort of assumes that we're starting from scratch. And for instance, we might continue to learn about similar barriers and facilitators or similar strategies that are effective, not necessarily building knowledge cumulatively. Can lead to reinventing the round or square wheel, right? So it's inefficient. It's also insufficient. So one of the reasons why it's nice to have robust frameworks in the field is that it gives us sort of a sense of the breadth of what's out there. What sort of things should we be looking for and systematically studying? This doesn't mean that we can study everything at once, but it does mean that we sort of at least reduce the risk that we are sort of just not shining a light on certain aspects of implementation that we should be looking at. So it's insufficient if we don't use frameworks because we may miss important factors. There's also increasing emphasis on understanding the mechanisms through which implementation strategies and other interventions work, and failing to use frameworks and theories really does not necessarily offer explanations for why strategies work or not. So insufficient in that sense as well. And ultimately, we might argue that it's unscientific. So failing to use frameworks or theory is really, it means that your work is based on an implicit idea of what drives change, which undermines replication and knowledge accumulation. So even if you hate theory, if you're one of those that said frameworks are, for the birds, essentially you already have something in your mind about why this intervention works, why this strategy works, and you're just not making it explicit. And so using frameworks is one way of doing that. Not sure why this is showing up that way, but this is also maybe in the field arguably a pragmatic necessity. This is a paper led by Enola Proctor years ago, where she noted a conceptual model and theoretical justification as a core component of writing implementation grants. So quite pragmatically, if you're writing in the implementation science space, if you're pitching a grant, if you are pitching a paper, including some theoretical justification or a conceptual framework is often necessary. That's not to say that you have to live with what's out there, that you can't critique theories and frameworks, that you can't extend them, or even that you couldn't propose an entirely inductive approach. But it does mean that you probably have to defend that decision if you're going to go that route. And so I think this is an important pragmatic necessity. For the haters out there are some dissenting views, right? So this is old and also perhaps a bit tongue in cheek, but there are a couple of papers that I think are interesting and worth keeping in mind. This is a group that says we need less rather than more focus on high level theories, less rather than more jargon, less dogmatism, more common sense, less theoretical work, and more rigorous evaluations that include direct measurement of important outcomes. And I think, though this is written probably 20 years ago, I think a lot of people still share this sentiment that probably we need more empirical work. Not necessarily that we jettison the theoretical stuff, but that perhaps we've become a bit too jargon heavy in the field of implementation science. To continue some ammo for the haters, the presence of underlying theory doesn't necessarily ease the task of judging the applicability of a piece of empirical evidence. It's not necessarily always clear how we translate theory into intervention design. So even if we use these frameworks, it's not always clear sort of how to apply them directly. And then there are many theories, formal and informal, and it's not necessarily clear why any of them should really be given primacy. And we'll see sort of the accumulation of frameworks in the field. Sometimes it's difficult to judge between them and sort of think which of these should we choose. Case in point, you may have seen this before, that frameworks are like toothbrushes. Everyone has one and no one wants to use anyone else's. So you see this phenomenon where people are actually, developing new frameworks in areas where they're not necessarily adding much to the field, or they may not have sort of relative advantage over what's already out there. Speaking to this proliferation of frameworks, our very own Rachel Tabak and Ross Brownson here at WashU years ago, this is 2012, they published a paper that identified, I believe, 62 frameworks in the field of dissemination and implementation. And that was really a foundational work for the field that laid out some of these frameworks, and would urge you to take a look there. This has grown over time. Depending on, there are numerous reviews here, depending on your review, that there are different numbers. This one identified 159 theories, models, and frameworks in this area of knowledge translation, which includes implementation science. And one of the things that they note is that 87% of those were used in 5 or fewer studies. So again, you see this notion of sort of homegrown theoretical frameworks that maybe not used more than just a few times. In fact, 60% of them were used only once. So I think one of the things that you see in the field is sort of a convergence around several very common frameworks. And one could argue maybe they're overused, but there is some advantage to sort of having a common use of few frameworks in some ways, and that we can compare across studies and hopefully have a common language across some studies. A more recent review critiqued the field in a number of ways. My colleague, I won't read this verbatim, my colleague Brian Weiner, wrote this in an email and said, but other than that, they're great, right? Like, but there are a lot of challenges. I'll note this, just the bold parts here. The provision of conceptually matched strategies to barriers and facilitators is not a common feature of many of these frameworks. There's little attention paid to the constructs of macro level context, stages of scale up and sustainability. And this is, I mentioned sort of the need to move towards theory in the field. The explicit inclusion of hypotheses or propositions were lacking in most theories, models, and frameworks. So certainly a lot of room to critique. I'll add one that the minister suggested yesterday, which is a lot of these frameworks have been developed in the global north, and maybe not as applicable, or a need to develop knowledge and frameworks for the global south. I mentioned the TABAC review. As the number of theories, models, and frameworks has grown, this is a very helpful resource, dissemination implementation.org, which basically allows you to search for relevant frameworks, primarily based on sort of the socioecological level that you're interested in. So if you're interested in either specific constructs or specific levels, so for instance, if you're interested in like organizational level implementation issues or policy level implementation issues or provider level implementation issues, this will allow you to search for that or even specific constructs, and it will spit out relevant conceptual models and frameworks for you to consider. There's also a number of useful sort of articles on basically guidance around theories, models, and frameworks. So would urge you to take a look at it if you haven't seen it. Years ago, we conducted some work where we were kind of grappling with this question of how do you actually choose between different theories, models, and frameworks, given this proliferation of frameworks, and can we provide some useful guidance there? And this is not perfect, but this started out with an international survey, and then eventually we developed a theory comparison and selection tool, which provides some considerations. I think it's really more of a decision aid. So I don't know how well you can see these boxes. Again, you'll have the slides, but things like the usability, testability, applicability, and acceptability of these theories on a number of dimensions. And there's an online tool that's linked below that actually leads you through these questions. And again, it's not meant to be like you arrive at the quote unquote right answer for the theory and framework that is right for you, but at least I think allows you to consider some of the key factors that you might want to think through as you're looking to apply this in your work. So one of the really, I think, foundational and helpful reviews was done by Per Nielsen from Sweden, and he identified 3 broad types of frameworks. The first are really process models that specify steps, stages, or phases in the implementation process. I'm going to give a few examples of those, or at least 2. The next is determinant frameworks that really specify, these are sort of the challenges, the barriers, or the facilitators that really influence implementation outcomes. So if we try to implement something, what gets in the way, what helps us, and how do we think about those types of factors that we might want to assess qualitatively, quantitatively, or using mixed methods. And then evaluation frameworks really specify what are the types of outcomes that can and should be measured as we think about evaluating the quality of implementation. So just going to give some examples here. And again, they differ with respect to sort of the specificity and granularity. This is the knowledge to action cycle, which was developed in Canada by Ian Graham and colleagues in an article titled something like Lost in Translation, Time for a Map. So really situates the full knowledge to action cycle, beginning from knowledge generation. They have a big emphasis on knowledge synthesis and evidence-based medicine up there. So you can see sort of this center triangle on knowledge inquiry, knowledge synthesis, knowledge tools and products. So you think about that as sort of starting at generating the evidence for a intervention. identifying the problem that it's addressing, and then determining the know-do gap. So what is the gap between what we actually know about the evidence and what we're doing in practice? And how can that evidence be appropriate for that? How can we then adapt that knowledge to the local context? Can we then think about assessing barriers and facilitators to knowledge use in a systematic way? Can we then think about how do we select, tailor, and implement interventions, monitor their use over time, evaluate outcomes, and eventually sustain use? And I think this framework is helpful, again, in providing sort of a broad map of where we're going with implementation. I like that it's cyclical. And so it suggests that we're probably not going to figure this out and that this is going to be iterative improvement over time. I also like that this can be used for those of you embarking on implementation research or thinking about this in your career. You could actually think about mapping the types of studies or work that you're doing to this at various phases. You might be very focused on one of these phases during a portion of your career. You might have projects that sort of span across this cycle. So I think it provides sort of a useful frame for those types of questions and purposes. Quite broad, but I think still useful. This is just another example of a process model or framework. I won't spend too much time on this. This is called the Quality Implementation Framework. And not sure how well you can see the box on the right, but considers multiple phases. So from initial considerations regarding sort of the host setting to creating the structure for implementation, creating the ongoing structure once implementation begins, and then improving future applications. And there are a number of sort of detailed steps in between that are sort of, in some ways, in my mind, like between implementation strategies and broad implementation processes. And so I think this is a useful framework. It's slightly more detailed or granular than the one on the previous slide. And we've actually used this in the context of an NHLBI funded R01, where we use this to actually sort of undergird an implementation strategy and describe the implementation strategy according to those phases and steps. And I won't, again, dwell on that, but if you want to take a look at that article, table 1 of that article shows how we sort of mapped our implementation approach to that framework in I think a useful way. So again, these frameworks are really useful if you're considering sort of how do we get from point, A to Z, and how do we consider the different steps of implementation that we're going to embark on. The next set of frameworks is really focused on how do we consider what are the barriers and facilitators or enablers, whatever word you use here. I'm going to use the word implementation determinants to talk about both barriers and facilitators here. One of the most common frameworks in this area is the Consolidated Framework for Implementation Research, or the CFIR. By show of hands, how many people have heard of the CFIR? So almost half here. So this might be old news to you. CFIR was originally developed in 2009 by Laura Damschroeder and colleagues, or published in 2009, and consolidated, I think at that time, 19 different frameworks in the field. And the idea was that many of these different approaches to thinking about implementation had common elements. So they consolidated those common elements into 5 different domains. So they had sort of the inner setting, or the organizational setting in which implementation takes place, the outer setting, so things like systems and laws, financing, external pressures that are external to the implementing organization. The innovation itself. So what are the characteristics of an intervention that make it more or less likely to be implemented? So things like the complexity, trialability. Can it be something that's easily tried and abandoned if not useful? And other factors that are oftentimes related to Everett Rogers' diffusion of innovations theory. They included characteristics of the individuals, and the recent iteration of CFIR includes both roles as well as sort of characteristics of individuals, including their sense of capability, opportunity, and motivation. And it also includes broadly the implementation process. So in a way, this is a determinant framework, but also includes elements that might be included in the types of frameworks I mentioned on previous slides. So this is super common. One of the sort of I would say one of the most cited frameworks. I looked at diffusion of innovation, the number of citations there that dominates in terms of the most popular theory in the field, probably. But this might be in second place. It's, I think, really helpful in giving us a broad sense of a lot of the things that are important. There are also trade-offs here, right? It's essentially a list of constructs. There's not necessarily much in the way of how these constructs are related to one another. And then again, with the level of granularity, for some of these constructs, you could actually dive really deep into any of them. So for something like organizational culture, there are reams of theories about organizational culture and climate and specific theories that you might want to apply to your work there. So this is useful as sort of an orienting framework, and oftentimes is a first step as we're doing exploratory work regarding barriers and facilitators in the field. But there are also ways in which we probably need to move beyond the CFR in some of our work. I'm happy to talk more about that. I wanted to note this this extension by Ariana Means at UW, who conducted a review and basically critiqued the CFR for its use in LMICs, proposing a new domain, which is characteristics of systems, and several, 11 new constructs that weren't in the original CFR. And I won't read these, but one of the things I like about this, and one message, one sort of take-home message, is that to me, all of these frameworks are meant to be critiqued, built upon, and probably too often in our field, we treat them as like static things that we need to apply with fidelity, and otherwise the implementation science police will, slap our hand or whatever. And so hopefully we can be freed up from that. We can critique these things and really build on the field over time. So despite the popularity of these frameworks, many of them we haven't taken the opportunity to really extend them over time. This is some work that we did to build upon the CFR work and actually allow it to match to implementation strategies. I'm not spending a lot of time on implementation strategies here today, but we've developed a compilation of implementation strategies called the Expert Recommendations for Implementing Change. And this work is based on an expert survey where we basically said, if we give you a CFR related barrier, so in this case, low reflecting and evaluating. So if, let's say, we have little or no quantitative or qualitative feedback about the progress or quality of implementation, nor regular personal and team debriefing about progress. And we said, what types of implementation strategies could address a barrier like this? And basically, we developed a tool that has different levels of recommendations. This is an Excel-based tool, so you can basically check off the barriers that you'd like to address, and it will give you the different strategies that that experts endorse to address those barriers. So in this case, level 1 recommendations, these are endorsed by over 50% of the respondents, would be things like develop and implement tools for quality monitoring, or audit and provide feedback. So measuring performance and feeding that back to the group of interest over time, oftentimes in comparison to their peers. There are a number of other recommendations here. Please check out the link and play with that tool if you're interested. I didn't mention on the previous slide, CFR.org has a lot of tools for both measurement, for assessing CFR constructs via qualitative interviews, and other sort of helpful resources that help you to use frameworks like CFR. Another really common one that you'll see in the field is the theoretical domains framework. And going back to CFR, I think CFR does a really nice job at sort of the collective levels. So including things like the organizational context, the outer setting. The theoretical domains framework was developed by Susan Mickey and a group of health psychologists at the University College London. And so it has a sort of decidedly individual sort of focus on professional behavior, though it includes things like social influences and environmental context and resources. You'll see from these constructs in the first 2 versions of this theoretical framework that many of them focus on sort of individual level constructs. Arguably, it does a better job than CFR at sort of capturing nuance at the individual level, though that might be argued by developers of different frameworks. But I think widely used in the field, definitely used a lot in thinking about provider behavior change, and wanted you to be aware of this type of framework. This is one example of how we use this in a trial. This is with Lydia Kwok, who's at Karolinska in Sweden. And Lydia is implementing an intervention that's really focused on improving the mental health of teachers in school systems. And so sort of a prevention intervention. And she had essentially a null trial, with null findings, and came back and said, how can we actually design this implementation strategy better? And so one of the things that we did was try to take a look at the implementation strategies we're using and what are sort of potential hypothesized mediators as defined by the theoretical domains framework, and how do those actually relate to things like fidelity to the guideline and ultimately their health outcomes of interest. And so again, won't go over this in a granular way, but tried to link the components of the implementation strategies to these various aspects of the TDF. So things like, are we addressing knowledge and awareness? Are we addressing environmental context and resources, et cetera? And how are we doing that? And the protocol paper that's linked below, I think provides a lot of details about how those strategies are operationalized, and how they're at least intended to work. And I think not the findings of this are still being written up, but much more promising findings than in the original trial. So whether this was the magic, I don't know, but at least we did better the second time around. To assess those theoretical domains framework constructs, we use something called the theoretical domains framework questionnaire at 3 time points, and that's noted here. This is just a really helpful resource that talks about both quantitatively and qualitatively using and applying the theoretical domains framework. And so we'll just leave that there for a resource. If you're interested in this framework, there's a lot written about it. And also some helpful web resources that I don't have on here. If you Google the behavior change technique tool, I believe you can find useful resources that connect the theoretical domains framework to behavior change techniques. And then I'll just note here, this is, I guess, maybe throughout, but there are opportunities to combine frameworks, and I'll give an example towards the end of how we might think about doing this. But I noted sort of the strengths and merits of both the theoretical domains framework and the consolidated framework. We actually conducted a review where we looked at people that were applying both. So though they're both, determinant frameworks that are meant to assess barriers and facilitators, people would use them because they thought, hey, the TDF is actually better at capturing this individual level, but CFR might be better at helping us to address or at least consider organizational factors, other collective level constructs. And so there's some use in that. There's, of course, a risk of being overly complicated, overly complex, maybe redundant with some of these constructs. So combining frameworks is maybe something that I would suggest that you do judiciously in your work. This is the last sort of determinant framework, and one might characterize it as sort of a determinant and process framework. This is called the Exploration, Preparation, Implementation, and Sustainment Framework, or EPIS, developed by Greg Ahrens and colleagues. This is originally developed for mental health, juvenile justice, social service sectors. And so if you're doing work in those areas, I think this may be particularly appropriate. It specifies different determinants at the outer context and inner context levels over these different phases of implementation. And so I think helpful to see how these types of determinants might change across phases of implementation. They also specify something called bridging factors, which really sort of help to bridge the inner and outer context. So things like contracting in sort of mental health or payment structures that actually help bridge the organizational context to sort of the financing structures are an example, would be an example of bridging factors. Rebecca Lennox Hall, who's on faculty here at the Brown School, her office is like right there, is someone who's written and really advanced the construct of bridging factors. So that's it for the whirlwind tour of determinant framework. Sorry, again, this is moving quickly. I think this is one that probably most folks are familiar with, but I don't want to assume that the REAIM framework, is that familiar to folks, at least in public health? Maybe fewer than I thought. So this is the reach, effectiveness, adoption, implementation, and maintenance framework. So I think, you know, a longstanding framework in some areas of public health, but is often used to frame implementation evaluations, and the types of implementation outcomes that we might see as sort of intermediate indicators that implementation is effective and leading to things like the effectiveness of the intervention and maintenance of the intervention. And so won't dwell on this, but they have a ridiculously extensive website at reaim.org, including like PowerPoint presentations if you want to teach this stuff, resources on how to use it, resources on how it's been used in the literature. I'm characterizing this as a determinant framework. They might bristle at that and suggest that it's also useful as sort of a planning framework and for other purposes in implementation science. So don't mean to sort of pigeonhole this, but it's oftentimes what you'll see as grounding evaluations in implementation science. Maybe particularly hybrid trials where we're trying to simultaneously focus on the effectiveness of the intervention and the effectiveness of an implementation strategy. And then since you're in St. Louis, I have to show this framework, but this is a common framework developed by Enola Proctor, who's a mentor of mine in the PhD program. And to this day, she does not pay me to provide this slide, but this is also quite common in the field. And usually I have this at the start of the presentation to sort of describe implementation, but you know, working from left to right, we have two different types of interventions, right? So on the left, I introduced sort of the 7 Ps, right? That's what's in that what box on the left. That's sort of the thing, if you will, that we're implementing. So programs, policies, pills, procedures, et cetera. Then the how is really the implementation strategies. What are the interventions that we're actually using to move that into routine practice? So like I mentioned, audit and feedback before as an example of an implementation strategy. You might have educational interventions, training, and the like. You might have work to develop implementation leadership as an implementation strategy, and so on and so forth. Ultimately, so we're in implementation science often dealing with those two types of interventions. Ultimately, we're trying to, hopefully move the needle on a number of different outcomes. Most of us are interested in sort of patient outcomes or population outcomes, right? Satisfaction, functioning, health status and symptoms, those types of things. Implementation outcomes are really the intermediate indicators that we're implementing an intervention well. So things like, is an intervention even acceptable, appropriate, and feasible for a given setting? Can we implement it with fidelity? Can we sustain that? Can we think about penetration or reach of the intervention? Can we sustain and scale that intervention? What are the costs of implementing the intervention? Those types of outcomes are often considered in implementation science. And so there are a number of resources, some I'll suggest on a subsequent slide for measuring those better. This is another area where there's been, I think, dialogue in the field. So Enola did a great job of sort of outlining these 8 implementation outcomes. Some of you might be saying, hey, where is scale up, or where, there are other outcomes that we might consider. So don't feel constrained by these, I think, but I think this is a useful guide to thinking about how implementation unfolds. So I mentioned, so this is partly from the top paper is the original implementation outcomes paper that really outlines those conceptual distinctions, contrasts those outcomes, and compares them to those that are laid out in REAIM. And they've since sort of returned to this work to revisit how are these implementation outcomes being applied. And Rebecca led a nice paper on practical recommendations for improved implementation outcomes reporting. And some of the additional slides I have after the conclusion of this, I outlined some of those recommendations and some tips that Rebecca had the 10-year reflection on this through their scoping review led by NOLA is also published here. And then I'll just note here on the bottom, so there's a website called implementation.outcomerepository.com that lists implementation outcomes that have been used in health from a systematic review done by colleagues in the UK. And then I'm also linking a special collection of the journal Implementation Research and Practice, where we actually conducted systematic reviews of each of the CFR constructs that I went over, as well as implementation outcomes. And so there are a number of published articles there that provide reviews of measures that rate their psychometric and sometimes pragmatic properties. So for instance, like how brief are they free, things like that contribute to their pragmatic use. 2 more minutes, Dr. Oskay, what do you think? So home stretch. I just want to point to this area. So I mentioned that there's increasing focus on mechanisms and theory. And I think maybe in brief, the idea here is that we want to be very clear about how our implementation strategies work to achieve our implementation outcomes or more distal outcomes of interest. And so there are various ways of mapping that. Many of you have probably used logic models a lot. There are specific manifestations of logic models in the field, including something called the implementation research logic model that J.D. Smith and colleagues have worked to advance. We've been using a process called causal pathway diagramming to basically, which is shown on this slide, to basically identify moderators that might influence the effect of implementation strategies, the specific mediators that are at play, the proximal and distal outcomes, as well as things like preconditions. So are there things that just need to be in place in order for an implementation strategy to work at all? The take home here is that there are probably various ways of mapping this out, but that we want tight connections between the types of implementation determinants we're addressing, the types of strategies we're using to address them, and the outcomes that we're trying to achieve, and that we should be doing a better job of describing the mechanism or the sort of how that actually works. What are the processes through which that works? And so I'll leave you with these slides just to make sure we have time, but we've been using various methods to do this. This is a paper led by Elvin Gang, where we're using a directed acyclic graph or DAG approach to this. So this is something that, again, is basically trying to think through how does this implementation strategy work? What are the sort of steps along the process through which it achieves our ultimate outcomes of interest? And so however you do this and however you depict this is increasingly important either in visual or narrative form. And whether you're sort of able to quantitatively assess this through formal mediation analysis or other approaches, or whether you're even, at sort of a more exploratory qualitative phase, we think it's important to think about this as you're planning, developing and evaluating implementation strategies. One more minute, Dr. Osgood? One more, I promise. So I'm just gonna sit on this slide for 1 second. And again, not a perfect example. This is an example from my career development award that focused on implementing an evidence-based intervention called trauma-focused cognitive behavioral therapy, right? And so this is sort of familiar. Looks like that ANOLA framework that I pitched up there. But I just want to show you how I'm using multiple frameworks to inform our approach here. So we have an evidence-based practice. In this, I have these 2 boxes to the right of that suggests sort of a method for selecting and tailoring implementation strategies. That's called COAST-IS, the Collaborative Organizational Approach for Selecting and Tailoring Implementation Strategies. This is essentially the intervention that we were piloting in this project, and used a process called implementation mapping to collaboratively work with organizations to tailor implementation strategies so that they were well fit for their settings. So this is sort of the use of a implementation mapping, which is not a process framework exactly, but sort of addresses that process element of implementation in terms of planning implementation strategies. The box to the right of that, implementation strategies, we could characterize using existing taxonomies. So we used our expert recommendations for implementing change taxonomy to sort of characterize the implementation strategies that folks were selecting. I have this assessment for determinants piece, which was based on the exploration, preparation, or and implementation, implementation sustainment framework or EPIS framework. And then we have the implementation evaluation, which was based on the Proctor implementation outcomes, where we're assessing for the intervention of interest, COST-IS, was that acceptable, appropriate, feasible? Could we get people to do it with fidelity? And then we also assessed implementation outcomes related to the clinical intervention, so fidelity to TFCBT. So just a quick example of how even in a single project, we might combine multiple frameworks to sort of guide our assessment of these constructs. And sorry, I don't have time to sort of delve into that more deeply. Again, I guess many bonus slides, but happy to have time for discussion and questions if we have time. Otherwise, happy to chat offline. I'm not sure if there's anything in the chat here. I'm seeing a lot of. Okay. Put him to sleep.
Yeah.
Did I say anything false? Maybe. Dr. Osgood is the okay. Not now.
Just for like where to begin? So you're writing your first grant. Oh, sorry. So Mark Huffman, WashU. You're writing. Imagine you're writing your. What advice would you give to people who are looking to incorporate this, but feel like, whoa, this feels like it's going to take a while to really pick up on all this stuff? Yeah, advice on getting started.
Yeah, maybe three responses. So one is like, this is a very collaborative field. It's a field that's focused, I think, a lot on team science. So even something I was reminded of recently is like, a lot of the grants that I'm involved in will involve even multiple implementation scientists. But phone a friend if you're completely new. I think finding somebody that's done this before is helpful. So collaborate. Two, if you're actually looking to get into this field and really learn more about it and are looking for places to start, there are a lot of nice sort of again, free resources, free trainings online that can give you the lay of the land and I think quickly get you caught up to speed on some of these frameworks and other sort of foundational elements. I think things like that, the dissemination implementation .org website that I put out could be sort of an initial step to explore different frameworks. But if that feels overwhelming, I think the best thing to do is actually consult with folks that have done this before. Even if you're not including them on a grant, if you have opportunities to consult with folks, just to give you initial ideas, I think that could be helpful. What would you add to that, Mark?
Start small. I started with a type 1 hybrid. So these hybrids are like process evaluation. So you're doing your regular study and you're just really understanding the process of it. And once you kind of get your legs on that, then you can do a type 2 hybrid. And then you do a type 3, so like, I feel like it takes a while to learn some of the stuff, but most of it you can pick up. You do just need somebody to kind of guide you a little bit, add them as a co-investigator. I'm on the study section for the science of implementation for health and healthcare, and we will criticize people if it's too complicated. So I think that's like early on, start just like anything. You start at the basics and build on it over time. Yeah.
Perfect.
Dr. Byron, can you talk to us a little bit about Bridges to Scale study to kind of, I know we didn't spend too much time on implementation strategies here, but kind of help us think about how to conceptualize and how to go about doing some of the actual work around implementation science? as an example. I think, that might be relatable for people to kind of, wrap their minds around.
Yeah, and maybe so so Bridges to Scale to me has been an interesting trajectory. I want to figure out how to say this. So in the sense that there were a lot of effectiveness studies, right? We have a very effective intervention. And I was talking to Dr. Masi about about Subi and other interventions where in a way you're getting pushed to do implementation studies. In some cases, maybe like implementation trials, I'm assuming. I don't know. I don't mean to speak for that study. Implementation trials before you maybe have done a lot of formal implementation work, like Mark was suggesting, like a hybrid one, where you actually are formally assessing barriers and facilitators and sort of doing some of that more formative work. And so the approach that we took in Bridges to Scale was to basically say, okay, we have great effectiveness studies. We're pretty confident in that. We want to see how is this actually more scalable. So how can we do this more feasibly, efficiently, cost effectively, and how do we not sort of and again, you tell me if this is not factual. You have more of the history than I. How do we not sort of slow down such that we're like, let's write an R21 or let's do something more sort of foundational to assess barriers and facilitators? And so we kind of tried to thread the needle between proposing a large scale trial, but also including enough formative work that we understood enough about sort of the barriers and facilitators to implementing and scaling this, and enough about the types of strategies that we might use. So in some cases, like it maybe isn't as I don't know what traditional is, but maybe not like the typical pathway for some of these implementation studies. But in doing that, we have an opportunity to engage, teachers, bank personnel, other community partners to assess what are the challenges to implementing this, right? And so conducting focus groups and other convenings to assess that. It also illustrates something like the CFR. So I think we said we're going to use the CFR. We're not asking about like 39 constructs of the CFR. We're asking pretty broad questions. We can later code those responses deductively using the CFR if we want, right? And sort of formally write that up in that way. So we're learning a lot, I think, about the context, about sort of the approaches that we might take. I think we went in with some assumptions about implementation strategies such as task shifting that might be effective, but ultimately that work will help us to operationalize the task shifting approach and to develop and sort of refine our implementation strategies that we'll then test. But the trial will also provide us an opportunity for, a formal process evaluation of those implementation strategies. So we'll come up with what we think our sort of best shot is. We'll conduct a trial, and then hopefully what we'll learn through the process evaluation will help us to further tweak and scale the Bridges intervention over time, or to at least think, get us closer to where we want to be in doing so. What was not factual, or what did I leave out of that narrative?
Like Dr. Byron was saying, we see a lot of effectiveness, but the research team is doing most of the work in terms of delivering the intervention, right? So then how do we, as a next step, move from heavily relying on the research team to deliver this intervention and kind of hand it over to the community so that they can sustain this intervention when we're moving on, right? And so this study is really hopefully gonna help us understand the best way to do that, so that that it can be scalable but also sustainable, right? Once the researchers kind of move out from the community, that the community can own this and continue to implement it.
Thank you. My question is, do I need a hypothesis in this implementation research? hypothesis?
Yeah, that's an interesting question. So I think a lot of our work, can and should be hypothesis driven. But we actually, maybe this is too much information, but it's been an interesting thing at WashU because through our work at the medical school, we're sometimes putting sort of just in time or pilot requests to the med school. And I think they're used to very hypothesis driven work, where some of our work is very exploratory, right? Trying to see, like, we're not exactly sure what the barriers to facilitators might be. So it might be sort of open, exploratory, descriptive at the beginning, and less hypothesis driven in that sense.
Thank you, Byron. My question was following on to what Oski had asked or explained of what it is that they're doing in the field. And I want to hear your views as to whether they cannot test that out in an effectiveness, a kind of approach rather than an information sciences approach. So she wanted to see if whatever it is that they're doing in the field could be taken on more by the community rather than the researchers. So why not do it in randomized,
Yeah.
no implementation, but I want to hear your views.
So if I understand the question, why not do this in the effectiveness studies,
Right.
and why not? Yeah. So my view, and actually we have some colleagues, Renat Betis, Lisa Saldana, and Rachel Shelton that basically published an article that said, hey, these interventions should be tested in the communities where they're actually supposed to be implemented, rather than spending all this time on sort of efficacy and sort of effectiveness studies that are still maybe highly researcher controlled and maybe in more controlled settings. So I'm generally sympathetic to that. And Mark mentioned this notion of hybrid, effectiveness implementation studies, and the sort of really a spectrum of studies along that spectrum. I think that we can and should do that earlier and more often. And so I think I'm sympathetic to pushes even in efficacy studies to start saying, can we start documenting the implementation strategies that we're using? Can we start can we think from the beginning about what's going to be scalable, and not sort of create implementation strategies and interventions that are going to be too much to actually be delivered in real context. And so I'm generally sympathetic to that. I think that we should be doing more of that earlier and often. Whether that saves the need for implementation trials down the line or not is maybe an open question, but I think, like, why not get more sort of real world earlier on? Especially if there's not I should defer to the MDs and others in certain areas. Like, I'm assuming these are areas where there are not, serious safety concerns. There are maybe areas in which we don't want to push too quickly towards implementation and scale up in the real world, and we need more controlled testing. So I don't want to gloss over that either.
I'm sorry. So it's actually still an RCT, and then we're still comparing the way we usually deliver it to the way that we will be delivering it, relying more on on community stakeholders. Yeah, so there's still that RCT element to it.
Yeah, thank you. Sorry, I missed that component. Cool.
Thank you very much for this great session. In terms of scalability and effectiveness, which of these frameworks might be more applicable within the African context to undertake the mental studies and be able to translate this and roll it out if you're looking at undertaking these RCTs?
So the question is, which of these frameworks might be
Yeah.
most applicable to scaling up
Yeah.
work?
And easier to use given the context within sub-Saharan Africa and the different challenges?
Yeah. The short answer is I have no idea. And I'd like to hear others' thoughts. I mean, to me, like they're just frameworks. Like they did, like it's not going to be like the framework makes or breaks a study, in my view. And that's for a couple of reasons. One, they can be applied with more or less sophistication, right? Like they can be something that you just refer to, and it might help you get the grant, but you're not actually using it, and it's not necessarily advancing our knowledge of those constructs. So I think like it's not necessarily the framework. Even when we talk about like downsides of the frameworks, it's usually sort of in my view, like not always the framework's fault. It's just sort of like we're using them for more than they are designed for, or less than they're designed for. In terms of what's the most relevant to that context, I don't know, and I think that's where I would invite commentary as you look at them, or as you scrutinize these frameworks. How relevant are they? What factors do you feel like are not fitting? And perhaps it means that we need new frameworks. I think that's an open question. I showed the sort of the extension of re-aim by Means and colleagues. I don't know if that's perfect. I don't know that any framework is going to be perfect in that sense. So I'm not totally convinced that your question is answerable, like that it will, one framework will get us there, but I'm not sure.
Thank you very much. I think it all depends on your patient health outcomes, because in all the frameworks, I think I didn't see that as one of the implementation outcomes. But what are the patient outcomes at the end of the day, as far as implementation is concerned? Then you can see whether it's actually scalable or it's actually effective. That's my view.
That's all. Thank you.
What's that? Yeah. Thanks so much.
Thank you, Dr. Powell. That was a great session. We're going to take a brief break now till about 10:15. Please make sure you're back in here at 10:15 so we can get started. But please help yourself to tea and coffee and snacks at the back. Thank you.
Okay. Once again, or not once again, a very good morning to you all. And welcome to our next session, our after break session. So people are still grabbing their coffee. We should be starting shortly. I don't see Dr. Prosi. Okay, we are going to we're going into our next session. I'll just I'll introduce myself for those for many of you that may not know me. The man from Kogelo. So my name is Timothy Opobo, and sometimes referred to as the man from Kogelo, sometimes also referred to as the official MC of CHILD for the last so many years. But it's an honor to be here. I affiliate with CHILD. I work with CHILD. I've been working with Dr. Fred for so many years. And it's always an honor to come and be a part of everything that is happening here. Before we start, allow me to do something. As we just get our energy levels up. And Tandy say, did we have a good morning session? We did. So we're going to do something very brief, something short, and this is what we're going to do. Since people are seated and people are still having coffee, we're going to use the weather to describe how we feel. So I'd like you to turn to one person just next to you and use the weather to say how you feel, right? So maybe you feel sunny, Maybe you feel bright, maybe you feel cloudy, maybe you feel rainy. And when you describe that weather pattern, you should elaborate why you feel that way. Is that clear? Am I clear? Okay, I know I don't want to give an example. Some of you may borrow my example and use it. You need an example. You do. Okay. I would say, hi, Stella. I feel cloudy because I didn't sleep very well, so I'm having a heavy head. So that's how I feel. Is that clear? So can you just do that very quickly? I'm just doing this to allow you finish whatever you have on your. Are we done? Yeah, so I need some examples. I'm just going to move the mic randomly and you're going to tell me how your neighbor felt. Is that okay? Randomly.
Oh. So I feel partly cloudy. My neighbor. My neighbor feels breezy. Do you want to tell?
Because I'm here. Easy breezy. Easy breezy.
Okay, that's a good one. Here.
I feel you. She feels sunny because she slept well and she's quite alert.
One more to go. One more right at the back. Can you share how your neighbor feels?
My neighbor feels sunny and a little windy at the same time because there's a lot going on, I guess.
Okay, so thank you. Are you done with your coffee? I want to do something that's more involving, but I don't want anybody to spill coffee on anyone. That's why yeah. No, we don't. Oh, so we don't have time. So we are going to go into our next session, but we'll do something later on. Please allow me to invite Dr. Prosi Navunya to come and moderate the next session and also introduce our panelists. Dr. Prosi, you're welcome.
Thank you, Mr. Timothy. He's almost graduating, end of this year. So good morning, everyone. And welcome for those who are joining us for the first time, welcome to our conference. For those who were here yesterday, welcome back. So I have a privilege of introducing the panelists for our next session. It's entitled NIH Funding Priorities, Navigating the Funding Landscape and Writing a Winning Grant. So our first panelist is Dr. Holly Rosen-Campbell. Oh, okay. Dr. Holly, like we call her, she's a program official in the Center for Global Mental Health Research at the National Institute of Mental Health. As the chief of the Human Mobility and Mental Health Research Program, Dr. Holly is advancing research on the mental health of mobile populations. She oversees a portfolio of research on the social determinants of mental health, which is broad in scope and includes studies focused on topics such as climate change, poverty, gender inequalities, and education. Prior to joining NIMH, Dr. Holly managed an extramural research program on psychological trauma at the Department of Defense, and as an AAAS Science and Technology Policy Fellow at NIH, she supported policy development for federal advisory committees and reported to Congress on stroke and childhood neurological disorders at the National Institute of Neurological Disorders in Stroke. Dr. Holly is a neurologist whose research examined the neurobasis of behavior with an eye toward understanding the evolution of underlying neurosecurity. I post that. So welcome, Dr. Holly, and we look forward to your presentation.
Thank you, Dr. Nabunya. I'm pleased to be here with you, or virtually. I wish I were there with
Dr.
you.
Holly, I think you're muted.
No. One moment. Can you hear me now?
Yeah.
Can you hear me now?
Yeah, we can hear you.
Well enough? Okay.
And it
Please.
sounds like the Zoom people can hear you, but not in the room. It's a
Okay.
technical issue. We are going to figure it out in a little bit. So, Dr. Holly, can you say something?
Sure. Can you hear me now?
Yes, yes, we can hear you now.
Great. Well, I was starting to say thank you, Nabunya. I'm very pleased to be here with you and your attendees. I wish I could be there in person, but I'll do my best to describe some of the work we're promoting at the National Institute of Mental Health. Let me share my screen. Okay, I will trust that you can see that unless you interrupt me. Again, I'm Holly Campbell-Rosen. I'm a program officer in the Center for Global Mental Health Research at the NIMH, and I'm going to tell you a little bit about our research priorities this morning. The National Institutes of Health's mission is shown here. I'll just let you read it for a moment. I wanted to emphasize that we have intramural researchers working on our main campus, as well as a very large extramural research community that receives funding to do their research, such as many or all of you. The NIMH structure is highlighted here on this slide. Across the top, we have 3 divisions that span from basic neuroscience research to translational research, and then services and interventions research on the far right. We also have 3 division centers and offices shown in the arrows that cross the entire figure. And the Center for Global Mental Health Research is one of those. We try to support research across this pipeline that's shown on the top. And many of the division priorities map onto our strategic plan, and you can see the 4 strategic objectives on the bottom of the slide. Our strategic plan can be accessed on our website, and as I mentioned, we have 4 goals that you can see at the bottom. But in addition to those, we have cross-cutting research themes shown on the far right: prevention, environmental exposures, comorbidities, and computational approaches. Our research in global mental health is also focused or highlighted in this region of the strategic plan. So this is one source of information that you can seek to find out our priorities. This is the landing site for the Center for Global Mental Health Research. And as you can see, we coordinate the National Institute of Mental Health efforts to generate knowledge that will improve the lives of people with or are placed at risk for mental illnesses in low and middle income countries. I'm going to talk more now about this center's priorities. But first, I'm going to mention that when our director, Dr. Joshua Gordon, joined NIMH several years ago, he identified some priority areas and developed teams that are across the Institute. And one of them is the Global Mental Health Team, and it's depicted here. It's a team comprised of individuals from across the Institute, such as our Office of Science Policy and Planning and Communications, the Division of Services and Intervention Research, which is probably applicable to many of your programs, and so on. And so everyone on this team has input to our priorities and review of grants and so on. It's a very interdisciplinary and highly collaborative environment. And it takes a perspective of how can global mental health research enhance the work of all of NIMH. This gets into our specific priority research areas, which are suicide prevention, integration of mental health healthcare, human mobility in mental health care, global mental health systems, and social determinants of mental health. To accomplish the type of research we fund, we focus on several supports of research, communication with the community, with partnerships, partners. We also partner with agencies worldwide to inform our priorities and to facilitate research. We have a very big emphasis on capacity building that I'll tell you more about, as well as training and career development. All of these pillars support research that we hope will increase the body of evidence necessary to inform decisions concerning adoption and scaling up of evidence-based interventions in in LMICs. And I'd like to point out that we are currently updating our research priorities, and they will be available in the coming months. They will be disseminated through notices of special interest, requests for applications, our newsletter, presentations such as this, and one-on-one conversations that you can have with our staff. This slide highlights the research pipeline, but in this case, it's inverted from what I showed you earlier. Implementation science is considered our near-term goals in the Center for Global Mental Health Research. That's shown in the orange box. We are primarily interested in the items in this box, but in the medium and long term, we have interest in translational and discovery research as well. So we're interested in treatment and prevention services, integration of mental health care into other systems, improvement of quality of mental health care, and optimizing training and supervision for non-specialists who often come from communities and engage in research. And the bottom arrow emphasizes that we are engaging with diverse populations, communities, contexts, and researchers globally. And we seek to expand research capacity in low resource settings and underserved communities. This slide shows some recent requests for applications that we published. Unfortunately, these are all expired, but I put them on the slide because they will provide you a good sense of what we're thinking about, how we think, what we emphasize in our requests for applications, and how you can pull those elements into your application should you apply for a future RFA. I've also listed a notice of special interest in the second bullet, which is focused on reducing suicide risk in young people in LMICs and low resource settings. This NOCI is still open, and if you are interested in suicide research in LMICs, I encourage you to take a look at it, and then it will provide you links to funding opportunities that are in line with this particular NOCI, and provide you that information so you can consider applying for different types of research mechanisms. Okay, I'm going to go on to the next slide. So we have a large emphasis on capacity building, and we have some 4 efforts here that I've listed. The first is some new language in our request for applications. If an application comes in requesting multiple PIs or MPIs, we require that one of those PIs have an academic appointment in an LMI institution where the research will take place. In addition, if a single PI comes in with an application, we encourage or require that the PI have a primary academic appointment in the LMIC in which the research is conducted. So these are things that we're striving for and hope that you'll take into consideration as you apply. We've conducted a webinar series recently that focuses on writing, submitting, and managing global mental health grants, and I'll talk about that more in a moment. In 2023, we held a global mental health conference that I hope many of you could have attended. At that conference, we awarded some up-and-coming researchers in their early career who have demonstrated excellence in research, a spirit of collaboration, community engagement, and a strong commitment to equity and inclusivity. And this was the Visionary Innovators Shaping Tomorrow's Advancements, or the VISTA Awards. You can find out more about the awardees and the program on our website. And then one of the RFAs that was on the previous slide is the Mental Health Research Awards for investigators early in their career in LMICs. And this has since expired, but we were able to fund several very promising early career researchers. And the idea was to stimulate research by such individuals and to promote research in LMICs. This is the series of webinars, lists a series of webinars that I mentioned. The 1 through 10 have already been done, but you can listen to the recordings and see the slides at the link that's in the slide on the bottom right. And I'm sure you'll get a copy of the slides if you're interested. We also have an upcoming webinar on June 20th that will discuss the NIH definition of clinical trials, which can be confusing and is very important to understand when applying. I'm going to briefly transition to some new priority areas that cut across all the NIH institutes and centers. In 2021, President Biden signed an executive order focusing on the climate change crisis. And this executive order requires that all agencies across the executive branch of our government engage in climate change efforts. And at NIH, there is an NIH-wide program called the Climate Change and Health Initiative. It has a strategic framework. It's published in this particular Lancet article that was authored by many or all of the institute directors, such as Joshua Gordon, who is the director of the National Institute of Mental Health. This initiative emphasizes the impact of climate change on health-related outcomes. And we have a strategic framework that you can read. It's shown on the right, and it's accessible on the web. And then in the middle is kind of our framework, the actual framework I'll talk about more next. So the idea is that we would want to build transdisciplinary teams and that they will address the climate change effects on health, including health equity, training capacity, building components, and intervention science. And we expect that this will happen globally, cross sectors, interagency, and involve many of our partners. And are anticipating that researchers will use the types of approaches that are outlined in the gray circle around the framework. So you can see it's a very broad approach to examining climate change impacts on health, not only mental health, but all types of health that is examined at NIH. The Climate Change and Health Initiative is currently led by 11 institutes, and you can see the directors here who are engaged in this program, including Joshua Gordon, our director, shown in the middle column there. So that is the sum of my presentation. I want to thank you for your time. I hope that I have time to answer your questions in the Q&A. Thank you.
Thank you so much, Dr. Holly, for that presentation. So please, you'll have a chance to ask questions after our third panelist. So our second panelist is Dr. Nolin Nakasuja. Where is she? Oh, there. So Dr. Nolin is is Associate Professor of Psychiatry and the Chair of the Department of Psychiatry at Macquarie University. She's also a Program Director for the Trainings Program. Dr. Nolin is a clinical research psychiatrist with many years of experience and expertise in mental health research, with a focus on evaluating special populations of HIV-positive individuals. Her research also centers around cognitive impairment of HIV/AIDS. She has focused her work on neurocognitive assessments across the lifespan, as well as other areas in the field of psychiatry. So welcome, Dr. Nolin.
Oh, yes, I do have slides. Thank you very much, Dr. Nabunya, for that kind introduction. As my slides are coming up, what's your mental health like this morning? Sunny? Okay, that's good. Anyone else with a different mental health this morning? Right. So, as you're all aware, there's no health without mental health. I mean, that's a slogan that is always talked about time and again, but sometimes we forget. And while I know the room may be filled with people from different disciplines, I'm hoping I'm like in a church. Sometimes I talk about church because we come from Africa, and church is a major thing in many of our communities. When you go to a church, you assume that everyone who is in there is a believer, or conforms to whatever is being said. But sometimes you may be very wrong. Sometimes people may be doing it for the sake of fitting in with society. Sometimes people may be doing it because maybe they are facing some challenges. And sometimes people may be there because they really want to, go pray and feel in contact with their God. So I'm hoping I'm not speaking to the converted or non-converted in terms of what it is that we're going to talk about this morning. When Laura asked me to make a presentation this morning, it was meant to be focused towards the trainees, for them to appreciate the funding landscape for an African researcher who is trying to come up in the field. So that's the main focus of what it is that I'm going to talk about. But Dr. Holly here has just given you what happens with NIH, which is just one of the many different places that one can be able to get funding. How easy it may be to get funding from other places, I do not know, but I'll still tell you about it. It's for you to navigate and see what it is that you may be able to come up with. So how much time will I have? Okay, you're the timekeeper. Okay, so I hope I don't get to use up all the 20, but if I do, you're welcome to listen. So the outline of what it is that I'm going to talk about today is why are we talking about mental health? And as I mentioned earlier, we may be converted participants to this field. I'll talk about the funding opportunities, the challenges, and what the way forwards may be for a young African researcher on how to navigate this landscape. Yes, so we talk about mental health because it's a basic right. Everyone needs to be protected from the mental health risks. And that's why much of the work that we've talked about from yesterday tries to target that area of trying to intervene early for people in order for to not be, to develop mental health problems, though we know that a good number of them already have these problems like depression and anxiety, the risks being poverty, which it is that much of the work that CHILD does tries to kind of alleviate in trying to take away the issue of poverty. And we'll go back to that point in a few slides down the road. We should be providing available, accessible, and quality care for individuals in regards for their mental health. And we should also be including everyone within the community. You know all about the stigma that is associated with mental health and challenges, and how people may not feel free to be able to access services even when they are offered. So from some of the presentations that were made yesterday by some of our fellows, these points did come out. And the reason we continue to emphasize this is to see how, as you grow into the future leaders for mental health research, you ensure that this doesn't continue to be, the talk of people avoiding to access mental health services. when they actually need them. So this map shows you a rough estimate of how many people may be suffering from mental health disorders the world over. The more red the place appears, the higher the rates of mental disorders. But I also want to point out that when you get to the African continent, much of the time it may be because there is no data. And we are hoping that you as researchers, as you continue to do work, you are going to help to fill up, this map with the right information so that we can map out, evenly with whatever else is happening in other places. But I also want to point out on this slide that, with the world population increasing, with challenges increasing in different communities, that the years lost due to disability as a result of mental health problems continues to increase. So, the world over, lots of things are happening. Increased urbanization, the challenges of social isolation, all contribute to people's developing of mental health problems. And to summarize what we were just saying before, we're a very big group of people in this room. I asked about your mental health this morning, and people said it's all sunny. But the statistics tells me that 1 in 8 of you may be having some bit of mental health problem. The degrees, of course, vary. The degrees, of course, vary on the severity of whatever it is that the person may be experiencing, and will also vary. But I just want you to be aware that this is, a fact. And unfortunately, some people end up with death as, the worst outcome for having a mental health problem. And this map shows you where most deaths may happen as a result of mental health problems. But still, as I pointed out with the previous map, Africa does seem like, people don't die from mental health problems, but still, I believe it's a challenge of missing data. For the people who are in the missing data session, I don't know how you were told to impute to fill in these spaces, but we need you to continue doing research so that you can be able to fill up this map so that it still evenly maps out. So how will you do this work? There are funding opportunities in different places. Dr. Holly was talking specifically only about the NIH. The slide I'm putting up here is about funding opportunities that are in the US. Now, as you can see, there are different bodies. Some of them are in agriculture, some of them are in energy. There are research councils that give money, there's project funding. So I'm not saying all of them give money for mental health, but a couple of them may be giving money to mental health, and it's up to you to search in there, just like Dr. Holly showed you before, that there are specific calls that come for specific problems that need to be tackled, and that's how you get to know where you can find money for the research that you need to do. I know for much of the time that US funds may require you to have a collaborating US person that you're working with. So will you get that money if you applied as an African researcher by yourself? Maybe. Well, you got money by yourself, Dr. Raymond, from Fogarty, but still, the link had to be created between WashU and Makerere University in order for you to be able to benefit from those money. So you have to be aware about the existence of those necessary prerequisites for you to apply for certain funding, because otherwise you may spend time trying to apply for money for which you're not eligible. That said, when you look at these calls, much of the time there's a section that also tells you who is eligible. Please do not ignore that section, because you will waste a lot of time applying when you have not fulfilled the criteria for selection. We are in the US, but as I said, I'll tell you about all other, funding bodies. So in the European Union collects money from all these different bodies that still fund research. And as I mentioned with the previous, some of them may be bodies that fund mental health, some of them may not. And still with this, I do know that sometimes you still need to collaborate with an individual for you as an African researcher to access these funds. Some of them may not need you to have one. The very common one that I know of, at least in Uganda, is the EDCTP that funds clinical research. And as an African researcher, you can be able to receive these monies as an individual. So what happens in Africa when it gets to this money? Who gives money for you to do research? Like maybe 4 slides back, I talked about, governments or institutions giving money to their own people. So in our respective countries, in this case, we are only talking about Uganda, but I know there are people who may be doing work in Ghana or somewhere else. Those countries themselves sometimes have research funds for which you can actually apply. They may be less competitive for you to get those monies. And whenever the opportunity arises, you should grab it, even when they may be giving you $3,000 to do work, or $5,000, like you have done with the CHILD-GRF. Please take the opportunity, because when you start out with whatever it is that is small, then eventually you build your portfolio for research. The biggest one I know of in Africa is the National Research Fund, but still the calls are specific and may vary from time to time. So you need to read the call in order for you to know what it is that will be funded. The institutional funds, rather the government funds, sometimes are very open to whatever research that it is that you would like to do, but still always look out to know what it is that they may be interested in. So the official development assistance funds are funds that are collected by countries that have a lot more, and this a lot more is directed to low resource settings for mainly development activities in those respective areas. So what you see up here are some of those funding bodies and the kind of research that they may be funding. You probably all heard about DFID, at least if you, from Uganda, because it does a lot of work, supports a lot of work in Uganda. The NIHR, which these are UK-based institutions. So the funding they give may be for projects, but sometimes there's also research that is embedded in these projects. And as to whether they will be targeting mental health, you still have to look at the specific call as it may come out to see if it's beneficial for you to apply. And I don't know if you've come across this table to my left that lists countries which are listed as ODA recipients. These are countries where this kind of money is from. What I've just mentioned, who can benefit? Uganda is one of them. The higher your gross national income becomes, the more you move away from being a recipient of those monies, moving this way. But still, for you to apply, you first need to check this table for you to know if you qualify. But for now, Uganda is one of them. And I list there that Chile and Seychelles and Uruguay you graduate from the list, the richer you become, and then you're no longer a beneficiary for this kind of monies. But for now, as an African researcher, you can be able to get money from this. And the amount of money that is given to do this kind of research is, as you can see in this graph, global health research, into which mental health may be encompassed, is a big chunk of that money. And then other, funds may be used for other development programs as may be necessary. But as I still mentioned earlier, you still have to look each time the funds are given to know the focus of where that money is going to be, concentrated in order for you to know whether you should apply. This is just a map showing how much money gets to the African continent, especially for UK funds. And as you can see, a lot of it is through the FID. So the question is, when this money comes, yes, we said that Africa is a beneficiary, but you can see that there are spots where much of that money goes versus other spots on the African continent. Some people seem to kind of be left out, and I don't know whether it's because they don't do research, which may be an explanation, or for this very specific slide, it was looking at research and development. So if you do a drug, if you do a device, this is where the monies go, and that's how they may be distributed. So we've talked about so much money, but how much goes to mental health? Unfortunately, it is that little red line you see on that circle. Very depressing. Yeah. So for example, you all know that depression is the leading cause of disability worldwide. But mental health, the whole of mental health, including depression, received only 128 million of the 37.4 billion monies that were for research in low and middle income countries as of 2016. Well, things might have improved since then, but still, it is still very limited. And I don't want to depress you that there's no money to compete for. Dr. Hoffman, he in this morning did talk about research and how you sometimes can be doing comorbid or researches that have comorbid outcomes, and sometimes you still can embed yourself in the other areas like HIV and AIDS, which is receiving a huge chunk of money, or other, health systems, or TB. I know Dr. Rachel did TB and depression research. So you still can see how you can embed yourself in the other areas, because as we said, there's no mental health, there's no health without mental health. So you can embed yourself in all these things. We are into schools, we are into families, and if you find that you can fit anywhere of these, still you can have the opportunity to do research. Yeah, so that was one of the facts, that there's very little money that is specifically directed to mental health. And yet on the African continent, where we have 15% of the world's population, and we bear 25% of the global burden of disease, only 2% of the research comes from, Africa. Now, what is not, what is clear is that we need to see how we increase this percentage of the research output. And if there's more research output, if we have more research questions that are considered pertinent to be answered, then monies can be directed to answer these critical questions. We have a very small mass of researchers in our setting to produce excellent work. We have limited progression pathways for those who may be in the scientific career, and this becomes a hindrance sometimes for people to continue to do research. There are limited research infrastructure and lots of challenges in people trying to navigate when you compare yourselves with counterparts in the high-income countries with inadequate support services. But that said, we want you to, keep moving, push on, because if you also get out of this space, then who will be in that space? And mental health will continue to suffer. So you need this money, some of you for, to get promotions. Some of you want to become professors. Some of you want, just to, someone was saying that they are research psychiatrists. Yeah, so they want to, they want to change their credentials. They mentioned to us yesterday. Some people just, want to have that label. Some of them want to do projects within the community. And why do you want to do all these things? I think much of the time we are doing all this research because we are in line with the WHO Sustainable Development Goals. Poverty is being one of those things that we need to see how we eradicate, as well as all the others. And I talk about poverty because it influences mental health a great deal. So in all that you're doing, you want to see how you contribute to, achieving those sustainable development goals. And how do you do this? You want to do this through partnerships with other people. You want to develop research questions that will help to fill research gaps and the needs of the communities where you're going to be working. But in doing so, you need to co-create. As we talked about this yesterday, you don't want to, jump in with whatever it is that you want to do without really appreciating what the community on the ground feels is their problem. And you want to test out actual problems whose results you can help input into policy. And I think the example you have received from the researchers that you see with iChad, that's the whole aim. And we want to create, how many of you? You're 18. 18 graduates with, in whatever field that you've decided to concentrate to improve mental health as a whole. And in so doing, build capacity in our setting. But you're not going to do this by yourself. You're going to be working with other communities. You're going to, other community bodies like the church. We have the bishop here. We have the father here. And you've all appreciated that what it is that the role they've played in being able to have researchers that will input into policy and in the end have a real impact on the SDGs at scale. We don't want, it's very good to do small researches, but we hope that as you do these small researches that they grow big. And that's why we're having the discussion on implementation science this morning on how, these things can get into real life and become big. But that said, I talked about some challenges earlier, but we do also have challenges in getting a good pool of mentors who can help you as you grow. So it's your role to look out for people that can, lead you forwards. Time allocation is usually a problem. Competing jobs, many times people are researching, but because whatever gets onto the table is not enough, then they're doing so many things at the same time. We have community responsibilities. Going for barriers is one thing I find that really takes up a lot of time. And yet if you don't appear, it's not okay for you not to go for people's barriers. And of course, the other stuff I talked about, like infrastructure. And so you need to learn how to navigate these. So as I conclude, Chelsea's looking at her watch, but as I conclude, their graduates, these pictures have changed in 3 years. So this was cohort 1, and as cohort 1, I mean, you already graduated, but you're also going to graduate again. And then cohort 2, this was the group that was in cohort 2, and then the last cohort here. As you all graduate out of this program, this is what we want to leave you with, that I mean, there's a reference for you to read this, but all these things identify with some of the stuff that we've been talking about here, about identifying and developing a critical mass of trainees, who you are, or we selected that you become, and then getting the right projects for you to work on, that once you're done with those projects, you actually publish the work out of these projects so that people can know what is out there, or continue to research on things that need to be researched upon, that you continue to apply for grants, and that you continue to develop a local research infrastructure, build a team around you, get others to collaborate with you in continuing research, and be very active locally based on the community in which you are in, and publicly engage, disseminate your research findings to them, and produce new scientific knowledge that would influence policy and practice wherever you are. So those are my references, and I'm grateful for all the support of everyone who works with us. Thank you very much.
Thank you so much, Dr. Nalin, for that excellent presentation. And again, you'll have time to ask questions after our last panelist. So our next panelist is Dr. Juliet Wellmore. Who is a professor of medicine and also an associate director of global health and dissemination at Washington University School of Medicine. She's a passionate advocate for health equity and sustainability. She's widely regarded for understanding how to make evidence-based interventions last, reshaping the focus on community engagement using participatory research, and improving the dissemination of health information while amplifying the voices of young people in health interventions. She combines more than a decade of authority and leadership in the use of dissemination and implementation science to deliver cutting-edge health programs that create tangible impact. She's been funded by NIH widely, and she continues her commitment to amplifying the next generation of researchers by leading the several NIH-funded studies, and you can read her bio on the website. So welcome, Dr. Juliet.
Well, good morning. And pardon my voice, I literally just flew in from Nigeria yesterday. So I think like many of you that were traveling, it's been an interesting journey of returning back home after being gone for a minute. So I'm going to talk a little bit about writing grants. They added the caveat of winning, which threw me off, because if you've ever embarked on a grant writing journey, winning is a hard one in that journey. And so when I was told to come speak about winning, I was like, wait a minute, I don't do a lot of winning in terms of my own trajectory with grant writing. But I'm going to talk about writing in particular, and hopefully on your journey towards writing, you know, may the roads be rough, like they say, and maybe you might win and maybe you won't win, but there are lessons to be learned along the way. So let's see. I'm going to talk a little bit about my background. Most, if not all, of the grants that I write are from the NIH. So I'm sure many of you are familiar with the NIH format. I have dabbled in National Science Foundation. I would always say that is not for the faint of heart. So if you've ever tried a National Science Foundation, you would know how difficult that is. But I'm much more comfortable with the NIH process. But there are many other processes, especially foundation grants, you know, Bill and Melinda Gates. There's so many other types. But the one that I'm most comfortable with is the NIH. And so I'm going to talk a little bit about that and some lessons I have learned along the way. And a little bit about future directions in terms of how you can take ownership of your own grant writing journey as you go along. And so my background, from that very first picture right there with malaria, up till the very first one, I think the very first picture you see there was when I had just received, I believe, $23,000 to do my doctoral work. My doctoral work was at, I graduated from Penn State University, and so I had received a pre-doctoral award, so National Institutes of Health pre-doctoral award, F31, if you know that mechanism, to really sort of diversify the biomedical field. And it was $23,000, but a hard-fought $23,000. Because I wrote it the first time, didn't get it. And so that's, as a student, that was my first experience of, oh, so you can write and not get, but you can revise because they give you feedback. And I didn't know that I loved feedback until that experience. And so that became like, okay, we don't have to get it, but we'll get feedback. And so what do you do with that feedback? And so I am grateful for that opportunity because it gave me, a sense of appreciating what it's like to receive feedback. And as a student, that's really what you want. You want to be able to get good, tangible feedback that you can then use to perfect whatever it is you're doing. And so this was, written my first year of doctoral work. So that's another thing about my doctoral program that I remain very grateful of. The first year for us was really grant writing, and Penn State was very good at that. Like, even though we all came into the program with funding, almost all of us that were selected into a doctoral program had 4 years of funding, but they just instilled in us this desire to want to go find more money for your work, especially if you're going to do global health. It was important that you learned the importance of making sure there's funding for your work. And Penn State had demography programs who were consistently funded. For example, I think they were the top 5 demography programs in those days. So consistent funding from National Institutes of Child Health and Human Development. Most of their programs have had decades of funding. And so it was important to instill in their students the importance of that. And then my experience with grant writing was from nurses, which was another interesting trajectory for me. I learned how to write grants from nurses who were successful at getting qualitative research funding, which is another anomaly because most of the times you hear about grant writing, it's very epi, it's very biostats, it's very quantitative. But my journey started with a bunch of, I don't know if you've ever read the book Morse and Field, so really top qualitative researchers who really had consistent years of funding to do qualitative work, which many people don't know you can actually get funding to do qualitative work, but these were just really top-notch nurses who were doing nursing research qualitatively. And so they, again, sort of opened my eyes to all the possibilities that can be when you write grants really from a qualitative perspective. And so, yes, that first grant was in ethnography because I thought, yay, malaria work, ethnography, let's go, NIH, biomedical work, we can do it ethnographically. And yes, it wasn't funded that first time. A little bit of NIH is still biomedical. It is still quantitative. But, when I came back and got the review, I was able to retweak it and went back again. And so from that first experience up until the one you see there, if the first one was 23, that one, which really became sort of the catalyst for me, was 6.4. And so 6.4 million. And so if my very first PI research was as a student at 23,000, I got an RO3 in between for about 50,000. And the very third grant I got was 6.4 million. So your journey can be yours if you define it your way. So people often tell you have to go through this way or go through that way. I guess I stand here saying you can go through your way, be willing to fail. So if we see that first journey of 23,000 up until the 6.4 million, there were a lot of failures in between, which I will talk a little bit about. Yeah, you see a little bit about that there. My failure rate is 70%, so I fail a lot. I fail a lot. I think some of my best grants are probably the grants nobody will ever see. But they are my best because you can think of the blood, sweat, and tears that goes into failing 70% of the time. It's a lot. And so the few people do see, it really is 30%, but the most people will never see is the 70%. But I think all of that, though, perhaps the most important thing about that whole journey is writing. You know, I think if I look back into, and I never really understood that until the pandemic 4 years ago, that the most consistent thing of all that experience for me is just this desire to write. And I think the more you write, the better it gets over time. And so I do keep a blog where I call it my mindless chatter or my stream of consciousness with writing. But by doing that or giving myself that space to just consistently write, and I try to write every day. So yes, that mantra of writing every day is real. I try to write every day, and just that consistent noise of letting it all out means that I get better at being positioned with what it is I want to do with grant writing. And so again, if you were doing NIH, this is NIH, and most of you know there's so much about it, so many institutes, so many, and I think NIMH, we just listened to Hillary Rosen, there's just so many institutes, and that's the other thing about it. There's so much you can do if you figure out what you want to do within NIH. Yes, the old ways of it is you should know the significance, you should know the approach. That's, if you go to any standard course, that's what they'll tell you to do. There's the PATS, the K process, or, you know, there's standards way they teach this, which I have no problem against, except that I say it doesn't give you the opportunity to appreciate and understand the many other paths you can take. You tend to lose excitement if you follow these paths straight-laced and forget the joy of discovery along the way. So I try to give people other paths that are not as clear-cut, that are very, you know, it's gonna take you everywhere. And I try to give, especially when I teach grant writing, I try to give a sense of feelings and awareness of why are you even writing this, and how you can use that to navigate your process, because this is what it looks like. And so it's not really winning. It's a bunch of this, and this was as of 2022. So it's a lot of discussed, not funded, a lot of withdrawn, discussed, awarded, but then not quite. And then you keep going. It's a lot of this, that path. It's a lot of this. And so you will see that a lot of, especially the withdrawns, you know, you put it all the way in and it's like, you got to withdraw it. There's a bunch of those there too, but it's a lot of this. But at least you face it, is what I say. Beno Chris would say that the most important thing is that you have to sort of keep facing as you go. And so you know, the most, and if you talk to any program officer, the most important thing they would say is you got to write, you know, so whatever it is, find your why, know the roots of why you're writing, innovate, innovate, innovate. That 6.4 million was because there was an RFA that specifically asked for innovation. It was probably the most complex grant I've ever written, but the key to that success was innovation. Time, I try to make sure my grants are ready at least a month before the deadline. So I emphasize that a lot. If I'm not ready a month before the deadline, then I can't submit. It's just, time matters to me, and then that persistence, and then dreams. So this is what like a typical process looks like. So this is in preparation for that 6.4, and I'm sorry you may not be able to see. It was detailed. We spent a lot of time with the detail of what that process looked like. And then we went on to this journey of the why, you know. So if you know anything about Simon Sinek, he would say, you know, find your core, find your purpose. You know, a lot of us know what we want to do or how we want to do, but we don't have a sense of our why. So he would say, start with your why, you know. And so that start with your why meant we went through a lot of changes. That involved, you know, is it worth it for us? Is it worth it for the people we want to work with? And if it isn't, then you probably are not writing the grant you enjoy. And so try to find, you know, what makes it worth it for you. And then as you do that, focus on the roots of why you're even doing this work. I tend to be very, as you can see, into poetry and art. Again, like I said, it helps me get better at writing, and by knowing my roots, I know, I guess maybe because of my history, I know I'm the one that was never meant to write something. I've always been told it's not for you, you're not the one. And so that helps me continue the work that I need to do, and especially who I'm writing it for. So I like to remind people that typically if you're writing the grants, it's typically not for you, but know your roots and hold on to it. Hold on to it because of the leaky research pipeline we find ourselves in. You know, a lot of the work we end up doing, many people don't see it. It's wasted, for example. Most people don't do systematic review. So part of my roots in terms of the extensive work we do with research with our grants is systematic reviews. Like every grant is like a mini systematic review on its own. We comb the literature for literally one line of sentence. That's how deep we go into the literature to find the gap. Partly because my interest is also sustainability. You know, of what use is this work if it's going to be effective, but it won't last. So we really comb the literature for the work we do. And then we try to think different. You know, this is an apple, this is also an apple. So, you know, you got to think different. You know, I think the reviewers have, I'm a reviewer too, we've seen a lot of research that isn't innovative. And if you can't answer that question and answer it well, then yeah, chances are you won't get funded. So innovation matters and thinking of that differently. And there are books that can guide you through as you think through what is innovation. I mean, that's really one of the questions I ask people when they come to me with, I have a grant idea. I say, all right, great, what's the innovation? And if you can't answer that for me, I feel like you need to go back and dig again. In terms of the literature. And then time, you know, I can't emphasize this enough. That cutting close is just not healthy for me. And many people, you know, I have an editor, so I really like to give my editor time. And so I try to do my work a month in advance so that they have the time to actually do a good job of editing. So I'm gonna skip through and then ultimately endure. Anybody that's gonna go through this journey ought to hold fast to the dreams that really began the journey, knowing that it can be the highest point of your life. And that dream is going to be full of, yes, ambitions of being successful, but also comes with dips. So in other words, if it's worth doing, you're gonna have a dip. In other words, you're gonna get this high and then you fall and it's like, okay, how do I get up again? But then you gotta push yourself up and dream again. And so this is what it looked like in the end. So if I showed you the beginning of really that detail of what that grant looked like, this was the version that was ultimately funded, and it became known as, it was innovative tools to expand HIV self-tested. For almost 6 years ago now, it became known as For Youth by Youth locally. For Youth by Youth gave birth to other children. So if in 6 years, we started out as For Youth by Youth, we've gone on to become For Girls and Women. For Youth by Youth has also become For Music for Health, and more recently, a center grant. So I don't have a single first authored cancer paper, for example, but I stand here to you today as a PI of a center grant, which is an anomaly, right? Because they tell you to do center grants, you have to have done so many things to get it, but innovation, thinking different matters, and you can create that journey as you go. Partly because you got to be the lions telling the story your way. Yeah, thank you.
Thank you so much, Dr. Juliet, for that excellent presentation. And thank you for normalizing failures and rejections, because we never talk about those. When you see a grant, you don't know that it has gone through 3 or 4 rounds of revisions to be funded. So, and we still have Dr. Holly online? Yes. So I have questions, but I don't want to ask questions because really this is for you, the trainees, but also people who, you know, want to ask questions about funding and writing grants. So I'm going to give you the first opportunity to ask questions. Burning questions? Yes.
Thank you, the three of you, for educating me.
And can you just introduce yourself?
Oh, sorry.
Dana? Yeah.
My name is Stella Ayo Odongo. I am from Uganda. Yeah, I think that's it. Not a researcher, so very new to this field, but an interested party. I can call myself a transitioning researcher from being an ordinary development practitioner into research now. So I've greatly appreciated your presentation, and thanks too for normalizing failure in research grant writing. I have been more involved in development work writing proposals. And I agree with you entirely when you say, both of you, when you say failure is normal, and when you say you have to keep writing and writing, many a time we fail to write because we think that we should just get that one win. So mine is just a question on how, I think it was Dr. Noeline and then the person who was online who talked
Dr.
about,
Hall.
Dr. Ollie, who talked about capacity building, and especially for me, who is just transitioning from development proposal writing into research grant writing. Is there an opportunity for capacity building? And then two, is there also where I feel maybe I am a bit advanced in age to learn? Could I then think about collaboration and partnerships for that I'll, for example, talk to Dr. Juliet or Dr. Noeline and say, no, I'm not good at this, but can we partner with you to write this grant? That is one question that I had. My second one is on, you mentioned the importance of process, and I think it was Dr. Juliet talked about the importance of process and how you navigate the process. Many a time we and importance of not giving time. Many a time we rush because we tend to baptize ourselves. You know, I'm a last minute person. I like doing my things last minute. How did you get yourself into that culture of doing that? And then my last one is just information. I know Dr. Noeline, you mentioned something about DFID. I think they've moved from DFID now, the FCDO. So I think from 2020, they changed to FDCO. So just information that they are now Foreign Commonwealth Development Office instead of DFID. Unless for the research element is different, but at least from the development work, I think they've moved to FCDO. Thank you.
Thank you.
Oh, thank you very much, Dr. Noeline and Dr. Juliet, for the wonderful presentations. My question is really on feedback. After applying for a grant, and then you see an email from them, and the first thing is your heart skips a bit, and you're like, okay, have I succeeded? Have I failed? And then you read, and it's a series of, oh, your application was great, but the computation was too stiff. But they don't exactly tell you why you did not succeed. And then how do you respond in that state of disappointment? And how do you answer that email anyway at the end of the day? Thank you very much.
One last one, Dr. Donnelly.
Thank you very much to the panel. That was a really, really great set of presentations. My name is Damali, and I am a pediatrician and researcher from Makerere University. So, and as an early career researcher, my question is how to track the calls, where to plug in. Many times you find out about it a month to the deadline.
Yeah.
True story.
Yeah.
So where do we plug in? I know that sometimes people even know about the calls that are coming before they come, and then they prepare all this time, and then along comes me who sees it a month before. And you know, how do we track these calls? Where can we plug in? Thank you.
Yeah. Thank you. Do you think we should answer those before they're coming? Okay. Dr. Julia, you wanna take the first step?
Or in my other institution, I used to teach grant writing as a course. So I think you just have to find who's teaching it. It's like poetry, like I say these days, it's like storytelling. There is an art to grant writing. And it's not something you want to take lightly. You do want to gain the capacity. And so I'm guessing iChat probably has capacity building courses, right? So just plug into where you can, because I don't think it matters transitioning where you're coming. So the other thing I didn't share was when I left after having that first grant, I went to the UN. So I saw what it was like to write for the UN in terms of grant. It's a different mechanism. I think we were doing UBRAC. It was a different mechanism. But they all seem to have the same story in terms of how you write grants. So that's why I say, that's probably why I stick with the NIH, because if you can have the basic aims, the basic objective, it translates, whether you're writing it for the UN or you're writing it for Bill and Melinda Gates, the same sort of structure of what people are looking for, connects. And yes, even though you've not been a researcher and you're coming back, I think the key is to write. I think if you have that desire to write, understanding and be willing to not succeed, so everybody wants to write the first one and it be successful, and you keep going. I applaud those who are successful the first time. It's great. But then also have that long game plan, and sometimes just get into it for the writing, and then be willing to keep learning as you go. Does that make sense?
Yes.
Do you have anything to
Thank you, Stella, for the correction on DFID. Too many acronyms for different organizations, but at the end of it all, is it going to give you money for your research, or is it more of a program-based kind of thing, which I think FCDO is more into that, more into programs. But just to add on to the issue of capacity building, yes, you can capacity build it. It's never too late. You're never too old. The opportunities when we put out our calls, we never put an age limit. It's all about what it is that you want to do and if it fits with, the call that we may have put out. So yes, the opportunities are available. But also, as you pointed out, the issue, you've already done program work. Now you want to become a researcher. There's still room. Of course, you need to acclimatize yourself to the research, kind of landscape, but there's no harm at all in collaborating with people who have already done it. There's no harm for as long as it's clear what it is that you are bringing to the table. Because you do have expertise in whatever it is you've done, and not everyone can know everything. You've worked with children, he's worked with children, you can still collaborate on, onto something, and you are both, either as you can start off as a co-investigator or a co-principal investigator, depending on whatever your expertise may be. That's in response to your concerns. And Damali, where do you get to hear about the calls?
Yeah. So actually, can I ask Dr. Holly that?
Okay.
So Dr. Holly, so the question was, how do we track the funding opportunities? And we know that sometimes some people come to learn about what is coming before actually the call goes out. So yeah, any thoughts about that?
Sure. So technically, folks should not know about a call before they leave. If you've learned about one, good for you, but it's not how NIH works. And then to your other point, how to find calls. At NIH, we have so many websites, and I know that it can be overwhelming, but there's one main website for NIH that will have all the calls. And then if you're interested in mental health, we also have a page for all of our calls. It will include open ones and then expired ones. And we have a newsletter, and that's one way we disseminate that information. And then something that I didn't say and hasn't come up is that to receive feedback or find out about calls or any kind of question you have, make connections with people like me, program officers, and have calls. And we're here, that's part of our job. And we're here to help you find the right calls, see if your aims are aligned with certain priorities and those kinds of things.
Yeah.
So please reach out.
Thank you so much. So Dr. Damali, those people who know about the calls before they come out?
Right. Yeah, but still beyond the websites, beyond the, the different funding organizations that you may know about, please collaborate, talk to the people around you, because sometimes indeed, when you ask that question, the stuff you get to know long before it appears on the website, and you start to prepare yourself. So if you work well with other people, they may let you know of, what's in the pipeline.
Yeah, and I have found the newsletters very, very helpful because they always have that information. So if you get to on the newsletter for NIMH or the different institutes that you're interested in, you get that information on a regular basis. Yeah. Okay. Another round of questions. Dr. Mpang. Before you ask, I'll ask one question in the chat. So this is from Dr. Andrea Balungo. She appreciated you for Dr. Juliet for sharing. So she's asking, I'm chasing my first big grant. So in particular, I appreciate you starting with your failure rate. A very practical question. How did you manage to stay funded before you hit your first big grant?
How do I manage to stay
How
funded?
did you manage?
So depending on the timing, I think I was writing the K word. So usually when you start as an assistant professor, when the first is everybody drills down, you gotta write a K grant. So I was writing a K. So I left the U and came to Illinois as an assistant professor, and I started writing the K right off the bat. And the thing about K, you should have graduated 2 years,
Right.
and I wasn't, and so I had to withdraw. So that whole year was wasted. But then I revised it and resubmitted. And in between writing the K, I also wrote an R03, which was just a small grant just to get a sense of the idea, because the idea was also, a little bit of it was proposed in the K, but then I wrote it as a small. And while I was waiting for the K to come in, the R03 came and I got funded for the R03. And so I thank the reviewers of the K, because even though the K was scored at a 30, because when I was revising the K and sending it back, I was like, oh, plus I got an R03. I was so proud, thinking the reviewers of the K will be happy that I got the R03. Well, the reviewers said, well, you don't need K then. Just go ahead and start doing your research. And so I was scored at a 30 for that K, and until tomorrow never got it. But then the reviewer said, just go ahead and start writing research. So that small R03 sort of propelled me to start.
Yeah.
And so we started.
Yeah. So thank you so much.
So start small.
Thank you all for the great presentations. This is enormous work. My first question is, now that we know that there is a failure rate, which is high, is it better to have several applications at the same time, different ideas, or do you slot in the same idea to different? Secondly, is the work-life balance. This is too much work. How do you balance up this with your family and personal life? All the stresses of failed grants and there are other obligations. Thank you very much.
So I heard different ideas. I heard work-life balance. What was the third one?
That was
Those two. And we didn't finish process, so that connects to the question on process. So it's different ideas. I think you don't want to only give the same idea over and over again, because reviewers are smart, and they can sift through. So especially if you end up in the call where the same group have sent the same similar idea. So you want to be clear. That's where that think differently matters. That innovation matters. I would say different ideas. Work-life balance is a good one. I am a mother of 4 children under 11. So yeah, my oldest is 11, my youngest is 3. So I work. So I have 2 roles, right? As a researcher and a mother. And I write in the morning, for example. I'm a morning person. So I try to get a lot of my writing done in the morning, because once the day starts,
It's hard with kids, if you have kids. Then I try to write towards the end. And then I am not hard on myself if I don't write throughout the day, if I have done it in the morning. And that's where that writing every day matters. People say, you want to get into the habit of writing. And I agree. I think if you can get into a habit of writing, it helps. Everybody will figure it out themselves. And I'm also the type that sort of blocks out time to write because I don't have a lot of time, if that makes sense.
Yeah.
Yeah. What about you?
Right. The idea of, I mean, Dr. Julie did talk about, the failures, but all this didn't happen in the same time slot. I've never actually counted how many failures that I've had, but you write and, you don't hear back, or they score you so poorly that you feel so demotivated that you do not want to even make a second attempt. But everything has to be done in time. For example, I mean, where would you have the time to, if you have deadlines, like 3 deadlines, all of them coming up in the same time frame, how will you be able to concentrate on that one grant and give it, a good input? So my suggestion would be that, if you do have a call, if at all you're going to have multiple applications, then they better not all be within the same window of applying. Work on one, work on it well. It's a lot of work much of the time. Good grants require a lot of collaboration, as we've been emphasizing. Where will you find the time to talk to Dr. Oski, incorporate the changes you have agreed that, should be in there, then, move on to another person. Sometimes, of course, coincidentally, you may find you have a new application and then you have a revision all coming in at about the same time. Well, then you have to deal with it that way. But to set out that I'm going to have 5 of them in 5 months, sometimes maybe maybe unrealistic.
One thing I would quickly add to her thing, have a failure resume, because she says she doesn't count her failure. I count my failures. And there is, if you quickly put my name on Google, you will see my failure resume. It's publicly available.
Yeah.
You should be proud of your failures. I can't emphasize that enough. Be proud of your failures, because that helps the journey to a success.
Yeah.
Once you own your failures.
Yeah.
So I strongly suggest having a failure resume.
That's great advice. One last question, Dr. Larissa.
Hi, here I am. Thank you to both of you for excellent presentations. My question is to our recent presenter. So I've been in academia in the US now for 12 years as an assistant or associate professor. And one thing that I realized over the course of my career is that I don't have time to fail too much. Because as you know, in academia particularly, we are evaluated on successes. That's how you're promoted. So at some point I had to define what is the trigger point that says, yes, I apply to this grant, and no, I will not apply to that because my chance of success is too low for the effort and the investment. And it was a really tricky thing to define, and it's tricky to communicate that because I was getting lots of invitations, apply to this grant with me, apply to that grant. And at some point I realized if I apply to all 20 of them, I won't have any one that's high quality enough to be funded because I'm spread too thin applying to everything. So I had to really define what will make me sit down and apply so that I am applying to something I am likely to succeed. I am most competitive for relative to my peers. And I wonder if that has been your experience too over time, the sort of more selective targeting of applications as you think about where do I put most of my effort so that I'm applying for what I can most likely succeed at.
And if I look through my trajectory, especially how I moved from HIV or blood pressure to cancer, passion became a crucial thing for me. And you're right, they don't reward passion, they don't reward all of that. But a death in my family meant that I was exhausted and tired of research not having an impact. And almost like enough was enough. And channeling that passion into anger, into writing, meant a whole new arena in cancer world came that I never, if you had talked to me 10 years ago, I never, I think I never ever thought cancer was in my pathway. So I mean, I don't do a good justice of this, but really what I teach is fund your dreams. I cannot decide, I mean, Toni Morrison said it, you know, we lose sight of our work if we don't take the time to dream. And the way towards whatever success may be in academia, we tend to tell people to stop dreaming. Meanwhile, it's the dream that will keep you up at night. I think over the years of writing so much, and I do not emphasize doing it, the writing means that I can find an idea and really get it done in 2 weeks. Because I have gotten better. It's like a marathon. You know, you don't just wake up and start running 25 miles. You got to start somewhere. And so over the years of consistent, once I see it and it connects with my subconscious, I can quickly turn it around because it's the dream that holds me through to the end. And I think how we find, and I mean, when I tell people you got to find our joy again in grant writing, because there's something joyful about it, that experience when you connect it to who you're fighting for. A lot of people were fighting for, a lot of communities were fighting for, and not here, right? So it's up to us to fight for that. And so when you have that, it becomes important where this work really is life-giving in and of itself. It's spiritual. I think for me, even it's spiritual. It's not enough that I have the opportunity to be here, but that work is not in service to many of my community members. I think once you connect with that, it becomes really natural. And yes, academia doesn't reward that. And you will find the energy, believe you me, once you connect to your dreams. And so, yeah, I say, fine, hold on to, I mean, Langston, he says it best, hold on to your dreams.
Yeah. Thank you so much for sharing, for your wisdom and for your encouragement. So please feel free to reach out to our panelists. They are very approachable. And you can actually reach out to Dr. Holly too. She encouraged us to reach out to her at the Center for Global Mental Health Research. So thank you so much. Back to you.
Great. Thank you, everyone. Thanks for bearing with us. We have 2 more sessions before we break for lunch. We're going to fit in our last cohort 3 trainee, Dr. Damali Nalwanga. She was unable to join us due to travel issues yesterday, but is now here and is going to be able to present her final project. So Dr. Damali is a pediatrician, assistant lecturer, and doctoral student at the Department of Pediatrics and Child Health at Makerere University College of Health Sciences. We can go down. Her doctoral research is focused on nutrition among children hospitalized with severe pneumonia with the aim of improving their treatment outcomes and overall health after discharge. She has a background training and experience in tropical health infectious diseases, particularly HIV, TB, and pneumonia in children. Her research interest in HIV dates back to her early years of medical practice at the Infectious Disease Institute in Uganda, where she was exposed to the unique multidisciplinary challenges HIV-infected patients and their families face. So we are thrilled to welcome Dr. Damali. So we encourage you to please give her your full attention so she can present her final pilot project, and then we'll move into our iChad speaker series immediately after Dr. Damali's presentation. Dr. Damali?
Thank you, Chelsea, and thank you, everyone. I'm really honored to be able to give my talk after all. I just want to let you know what I've been up to during the years that I've been on the CHILD-GRF program. Okay, so my work is titled Understanding Knowledge and Attitudes of Caregivers about the Impact of HIV on Neurodevelopment of Children of School-Going Age. And my mentor is Professor Philippa Musoke, who sent her apologies. She could not join us today. So by way of background, children living with HIV are at significantly higher risk of neurocognitive impairment compared to those who are HIV negative and even to those who are HIV exposed but uninfected. And I list only one study here, but it is a systematic review of so many papers that can attest to this fact. Now, there is another systematic review of about 32 studies that shows that HIV-infected children actually do struggle with school. And the specific domains that they were able to analyze were general learning, mathematics, reading, among other things. And this is even a study from a developed setting where they were able to assess that HIV-infected children were more likely to require special educational services. So you can imagine, given the differences between the developed and developing countries, this problem is likely to be even much worse in our developing countries. So from that, we know that HIV infection threatens children's potential productivity later as adults, because your achievements later in life depend on how much you learned during the time that you were in school or when you were growing up. So there's been several interventions that have been tried to try and help HIV-infected children to learn better or to, to prevent neurocognitive decline, really, to limit the neurocognitive decline. And they have been widely studied and tested, and they have varying results. And I think that part of the reason they have varying results is because the implementation and impact of these investigations is contingent on how much the caregivers or the people we task to continue with these implementations understand how much knowledge they have and what their attitudes are towards this particular problem. Because when they understand what's at stake, then they're likely to be able to embrace this implementation, the implementation of these different programs. And that eventually improve active stimulation of their children at an early age, or for healthcare workers, increase their index of suspicion, screening, and also utilization of the different neurodevelopmental interventions that have been tested, or at least link them to care, to this sort of care. So the objective of my study is to explore caregivers' understanding, knowledge, attitudes about the impact of HIV on neurodevelopment among children of school-going age. So it's a qualitative study, and we're going to have key informant, in-depth interviews, as well as focus group discussions. And the caregivers that we are going to interview will be purposively selected. That is, parents and guardians of children living with HIV, and then different care workers, healthcare workers, different cadres, including counselors, nurses, medical officers, and pediatricians. And we shall use semi-structured pre-tested guides with open-ended questions in logical sequence. And then we shall go through the standard qualitative methods, audio taping interviews, transcribing them verbatim, and then analysis will be done using in vivo. So what's the innovation here? Most of the HIV interventions have focused on the children. So prevent them from getting HIV through, prevention of mother-to-child transmission, or treat them early. And all these have been useful to some degree. But now we need to focus on the support systems of these children. And why is that? The problems of school functioning cannot be solely actually attributed to HIV. For many of these families, there are multiple socioeconomic as well as cultural factors that play a role. And this very study that I quoted here showed that even siblings of HIV positive children who are themselves HIV negative do not perform as well as their peers. So I think we need to shift our focus to now the support systems of these children. And that way we shall be targeting a larger sample of children who need to benefit from these interventions. So what have I done so far? I have had my protocol approved at all levels. That is the Ethics Committee, as well as the National Regulatory Council. And I have been able to get administrative approval from the institution where I will interview parents and guardians. And I have a participant screening going on right now. And hopefully I will be able to start data collection as soon as I get back home. And then I'll go on to the process of analysis and then prepare a manuscript and peer-reviewed journal. I hope to do it over the next 2 to 3 months. I also hope to apply for a care award. Yes, following the last discussion, I have actually started that process already, and I've reached out to people to support me. I have talked to a program officer, thanks to Dr. Fred Zawamala and Dr. Nabunya. And one of the key things that they have recommended is that I finish my PhD first, which is where I'm putting my effort now. Other achievements. I have gained the confidence to communicate scientifically and put myself out there, especially in the neurocognitive space, which is not my primary area of training, just an area I like very much. So I've been able to read and put myself out there and get the hard questions because they can only make me better. So I've been able to present at many conferences locally and internationally. I think for the last two at the bottom, I was actually at conferences in Paris. So I've also been able to travel, which is great. I have been able to increase the number of publications significantly since I joined, as well as get collaborations. When you travel or when you start to write, then you reach out to people, then you know more people, then people, then things go on from there. And also the number of grants have increased where I am a collaborator, and also a grant where I am actually a co-investigator along with my, my supervisor. And I had to take some time out, as most of you are aware, and that is my very meaningful detour. And while people were talking about work-life balance, mine is right there. And I thank everyone who was able to support me on that journey. And finally, I would like to appreciate the CHILD-GRF family. These guys have really made me better. We sit every so often and review each other, peer review, and they tell you what you're doing doesn't make sense at all. Thank you, Dr. Noelin. And then I'd like to thank, no, she just leads it. She's not the one who says that. She leads the discussions. She moderates the discussions. Yes. And then I'd like to thank the grad PIs for this opportunity. It's definitely, like you have had, some people, we are going to start by applying and failing, but at least this was low-hanging fruit and they gave us the opportunity to start by winning. And yes, I'd like to thank my mentor, Professor Philippa Musoke, and my family, without whom this would have been a very challenging experience. Thank you. Thank you very much.
And I know there might be some questions, so we'll take 2 questions for Dr. Damali. If you want to raise your hand, and Dr. Damali, you can answer.
Thank you very much. Very interesting. I'm just wondering how you manage, because in this study, you look as you're administering the questionnaires, you realize someone's educational status, financial level can actually influence the response to these questions. How did you manage to rule out this? And then also you realize some children could have been adopted, okay? Maybe the caregivers are actually not the actual biological parents, but because they would want to show that they're actually positive about the child's status. So how did you cater for that psychological impact? And then also the group focus, the group questioning. How was this managed, issues of confidentiality and privacy?
Okay, thank you very much for your question. I've actually not started the work. Like I said, I had to take some time away, but these are all really important things that we have been discussing as a group, and that's why Professor Noelin is nodding her head like that. These are things that we've really, really discussed extensively. There are things that I can't do perfectly, at least not in this time and space. I have purposively selected, I'm going to purposively select participants from the Makerere University, Johns Hopkins University HIV clinic. And this clinic is attended by people of a wide range of people of, you know, different socioeconomic status. But I think it is quite representative of all of the kind of parents that you'd expect in, you know, in Nakaseke or in other places across the country. Yes. And so we are trying to include as many different age groups, include people who are actual parents and those who are caretakers that are not directly parents or guardians and that sort of thing. So we are trying to find a representation at all levels. And then in terms of confidentiality, as far as I can go is to within the research structure, only use interviewers who are trained for the purpose of the study and have done GCP and therefore know about the need for confidentiality. And then within the group, part of the consent is explaining how far that confidentiality goes and what people need to expect from the research team. Between the different, the people that will be involved in the study, that's a hard one that I would have to think about some more. Thank you.
Thank you so much, Dr. Damali. All right, we are ready to do our last session before lunch. We are going to welcome up Dr. Praskovia to moderate this next speaker series. So welcome up Dr. Prosi. Thank you.
Are we here? Physically, emotionally, spiritually? Are we here? Let's just stand up. I think we need to. Let's stand up. 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 So we're going to try out something. Just stretch a bit. Just before our next session, do I have your attention? Okay, I learned very recently, actually yesterday, I was told that there's been an increase in the level of criminal activity around St. Louis. So, follow me. So, because of that, the community around St. Louis has gone to the police and asked that the police do something about it. Right? And the police said they're going to do something about the criminals. So there are three categories. We have the community around St. Louis, we have the police, and then we have the criminals. So I'm going to divide you into those three groups very fast, right? Very fast. This up to that point, they're just behind Dr. Ebo. You are the criminals. So these are the criminals right here. You're the community. And this is the police. Are we together? So this is the instruction. Can the criminals put up their hands for recognition? Yeah. Can we have the community put up their hands for recognition? And then the police. So this is what happens. Just, you have to follow me. If I mention in the statements I'm going to make, if I mention criminals, then the criminal will sit down, right? And if I mention community, then the community. But if, when I mention the next group, the other group stands up. Are we together? Okay. Did we get the instruction? Huh? Yes, no? Yes, okay. So, let's go. So, recently, there has been outrage in the St. Louis community because criminals in the community continue to destabilize the community. The police have been approached by the community, but the criminals, no, if I mention your category, you stand. And if I mention that category, then the next one sits down, right? You don't stay standing. Are we together? We have to try this again. So listen, if I say the criminals stand up. And if I go to and say the community, then the criminals sit down, community stands up. So you have to keep listening. Are we okay? So everybody sit down. You stand. Then when I mention the other, you sit. If I mention your category, you stand. If I mention the next category, you? Okay. So the criminals have become a very big problem to the community. But the community continues to insist that the police do something about the criminals. And the police are saying that they are going to partner with the community to ensure that these criminals do not continue to ravage the community. Unfortunately, the police are saying that there are just not enough personnel within the police to help the community fight the criminals. We can do the next session.
Ooh, I was part of the criminals. That was excellent. Thank you, Timothy. And so you know they're not criminals here. It was just an exercise. So very exciting panel that is coming up next. We are very, very happy to introduce our CHILD-GRF trainees. They're going to be presenting on their own projects. These are the final presentations. So we are so proud of you. So our first speaker is Dr. Rachel Alinaitwe. Where is she? Oh, there you are. Dr. Rachel is a practicing psychiatry and researcher. She has expertise in mixed methods research in community and hospital-based settings. She's passionate about mental health for vulnerable populations, especially adolescents and older persons. Her CHILD-GRF fellowship, she has focused on the detection and referral of for depression among adolescents living with HIV. And she's also currently a PhD student at Marquette University, and her research is on unmet needs for caregivers of people living with dementia in Uganda. Welcome, Dr. Rachel.
Good afternoon. Yes, as I've already been introduced, I'll be talking about detection and referral of depression among adolescents living with HIV in Uganda. My mentor, Dr. Dickens Akena, should be around. I think he has stepped out briefly. And so we know that it's actually an open secret that mental challenges, mental health disorders are common among adolescents with HIV. And the Ministry of Health in Uganda does recommend integration of mental health services within the care of HIV. But is that what is on ground? We're not quite sure. So we set out to determine whether depression is screened for among adolescents living with HIV in care. And then we also set out to assess the effect of a self-assessment on a computer tablet by adolescents on the rate of detection of depression. This was a quasi-experimental study, which was conducted at Baylor, a center of excellence, a tertiary HIV treatment center for adolescents, and we had a historical control. So we did a chart review of 425 records over a 3-month period, July to September 2021, and documented the number of adolescents that were screened for depression and referred for care. We went ahead to do a primary study, primary data collection, sought consent from an equal number of adolescents aged 10 to 19 over a 3-month period, same time of the year, July to September in 2022. We collected social demographic characteristics from these adolescents, who then proceeded to self-assess for depression using the PHQ-9 adolescent version, which was incorporated onto a computer to give us what we call a computer-assisted self-interview. On that computer-assisted self-interview, all positive screens for depression, which was a score of 10 and above, had a prompt referring them to the clinic counselor to receive mental health care. So we note that from the primary data collection, we had 52% being males with a median age of 16, and all of them had attained some level of education, the majority having attained primary level of education. And because they were school going, 97.7% were actually single. So we compared the screening in chart review versus that of the CASI. And it's very shocking to note that out of the 425 records we reviewed, there were only 6 adolescents screened for depression. And that was with a PHQ-2. And surprisingly, none of them screened positive for depression. With the CASI, we assessed 425, and 99 screened positive for depression, which translates very well with the literature showing a prevalence of about 23 to 26% of depression among these adolescents with chronic physical illnesses. So just to elaborate a little bit, of the 99 that screened positive for depression, we see that, I don't know where. We see that 59 of them had moderate depression, 30 had moderately severe depression, and 10 had severe depression. Of the 425 we screened, 95 had active suicidal ideations. The PHQ adolescent version gives us an option to assess for whether an adolescent has ever tried to commit suicide. And it's very shocking that 14% of these adolescents had ever attempted to commit suicide. These are 10 to 19-year-olds. So as I said, on the CASI, we had a prompt for self-referral to the clinic counselors for those that screened positive. So the 99 were all prompted to go and see the clinic counselor. Only 15 went, which is a response rate of about 15%. Of those 15 that went, 7 had the counseling session related to why they were sent there, depression, suicide. The other 8 had the counseling session not related to why they went there. And as we can see, 84% did not respond to that prompt, so they never reached the counseling point. In conclusion, we see that the use of the CASI does improve the rate of detection of depression because we were able to detect the average prevalence as per literature of 23.3%. However, the adolescents are unlikely to seek care for their mental health symptoms following a simple prompt. Therefore, there's need for more awareness of the available mental health services at the Baylor College of Excellence, Center of Excellence, and possibly actual linkage of these adolescents so as to facilitate their access to care. Because we see that even the 15 that went, half of them had non-depression related counseling. Yeah, so as I finish my journey, I have 2 minutes. I think I'll just talk about my achievements so far. Yeah, I've been able to finish my work, presented my results here, submitted my manuscript. I've just responded to reviewers' comments in BMJ Pediatrics. So I'm waiting for their next feedback. And as I was introduced, I'm currently a PhD student at Makerere University. Through this fellowship, I've been able to have 3 first author publications with 2 in review. And I've been able to have 5 non-first author publications with about 3 more in review. So for me, it has been a very excellent journey, a very interesting phase of growth with so many new things learned, how to manage my time, how to collaborate, how to be a team player, how to balance my life and work. I used to be overburdened at the beginning of this fellowship, very confused, but I have learned where to say no, where to ask for help, where to say this I will not do, and this is not for my own mental health. Hey. So thank you very much to the entire team that has helped me along this journey. I'm forever grateful.
Congratulations, Dr. Rachel, for those accomplishments. We are so proud of you. And so for our next panelists that just know, I'm going to ask you about your failures as well in the program. We have to celebrate them. So our next panelist is Dr. Raymond Atwevembele. He's a medical doctor and also our own student in the Masters of Public Health here at the Brown School. He also serves as a research assistant for ICHAD. Dr. Raymond has a passion for mental health. For his project as a CHILD-GRF research fellow, he has specialized in the study of suicide behavior among adolescents living with HIV. He's driven by a profound commitment to unraveling the intricate relationship between mental health, its associated risk and protective factors, and chronic diseases with a particular focus on early interventions aimed at improving adolescent outcomes. So welcome, Dr. Raymond.
Thank you so much, Dr. Percy. Good morning. It's a pleasure to be here, a privilege and an honor. Can you hear me? Oh, yes, I'm glad to hear that. So, better this way? Okay, perfect. So I'm Dr. Raymond Atwembe as presented, and this is my research project. So shout out to my dad, who is in the audience. And my and my lovely sister, but I think okay, I have very limited time, so I'll try to push this along. So my story with suicide is a bit personal. I lost a friend to overdosing, and that is where I correlated with my sister Stella's story, where she said that sometimes you do not need a lot of evidence to get into the field of research. Sometimes that one experience can be what you need to actually influence you. And when I decided to go into this field, particularly looking at suicide, it was backed by evidence. And what data shows is that globally we have around 800,000 people that are being lost to suicide. And this is among the adolescents aged 15 to 19 who die annually. To come into a more contextual outlook, the Chaka study that was carried out in semi-urban and urban Uganda revealed that the prevalence of suicidality, as reported by caregivers, or as by adolescents and their caregivers, was up to 10.7% and 2.8%. What we must understand is that adolescents who live with HIV have adverse circumstances that they deal with, compounded with the chronic disease, chronic medication, sometimes a lack of social support. And sometimes those who are in school face challenges of being bullied, or the stigma and discrimination that comes along with living with HIV. The issue with suicide is one for me that, unlike other mental health illnesses, is that it has one outcome once it is successful, and that is death. My study design was a prospective cross-sectional quantitative study, which had two basic aims: to assess the prevalence of and the factors associated with suicide behavior amongst adolescents that were diagnosed with and living with HIV. Particularly, I was set out to recruit from Tasso Masaka, the AIDS support organization, where 150 adolescents were recruited. Major inclusion criteria were mainly two: adolescents that were aged between 12 to 17 years and those that were diagnosed with HIV. Consent and assent were obtained separately between the adolescents and their caregivers to prevent coercion. There was IRB that was necessitated to make sure that this study pushes forward, one of which was from UVRI, Uganda National Virus Research Institute, UNCST, and then of course I had to get a memorandum of understanding and working partnership with TASO. So three IRB bodies had to approve for this to go forward. So table 1 shows my results from the study. And this is a bit compressed, yeah, because mainly of time, and yeah, it's a bit compressed, but in the publication, you'll see a much broader table. There was a 50% distribution of gender, and 70% of the adolescents said that they had lost their father, and 22% had lost the mother. Sibling bereavement was at 37.3%. As you can see, the region is mainly Catholic area, so the highest count was for was among the Catholics, who were at 53%. So the scales that were used to assess some of the risk factors I looked at was the UCLA scale, which is assessing for community satisfaction, the CHILD-GRF assessing for depression. So the UCLA was for loneliness and social isolation. Then the CHILD-GRF was for depression, and I used the Columbia Suicide Severity Rating Scale to be able to assess for suicide ideation and attempt. Table 2, has it changed? Has it? You can see it. Oh, okay, perfect. All right, so I'll bring your attention straight to loneliness and social isolation. So these are defined differently. Loneliness can be, as described by psychology. Today I'm going to paraphrase. Sometimes you can be lonely in a crowded room, as we are here. You have your connections with you. You have a presence around you, but you cannot make that social connection and achieve that utility. Loneliness, on the other hand, is more of an intricate situation whereby, or socialization, on the other hand, is more of an intricate situation whereby an orphan child may grow up with only one caregiver and a lack of social support. You can see how it stood out as an association for suicide attempt and suicide behavior, respectively. R squared shows a variation, which explains how much of our predictors cause a change in our outcome. And as we can see, we had a 0.16%, which translates into a 16% change in our outcome of suicide ideation as a result of our predictors. And on the other hand, 13% change in suicide attempt as proposed by our predictors. So there is, supported by previous research and ongoing research, there is an interplay that loneliness and social isolation contribute to suicide behavior, and we cannot negate or forget about that. Following the crisis of COVID-19, this has worsened these conditions, and it is our role to actually reach out and be better people to one another, to be able to be a social support to each other. Implications, there are quite many here, but I'll brush down to this. We should be able to have better methods of risk communication and risk perception amongst the people that we are trying to reach. Because as scholars, we understand some of these figures and some of these outputs, but what does that mean? And mostly in a country like Uganda, where suicide is culturally sensitive, and you may not want to bring out this conversation openly. In some cases where it happens, it is denied as the cause of death. So we have to find a way of entering the community to be able to address some of these issues delicately. Thank you. Delicately. So to be able to design curricula that target both in and out of school going children, because we cannot think about one and not the other. The room here is full of diverse groups of people. That means we have a global representation of the backgrounds where we are from. It is our role to bring that agenda forward and support our people. Then, as my sister said right before she left, we need to have comprehensive care that engages mental health care so that people who are at risk can be able to be catered for in times of need. And this will be important to mitigate some of the ideations and even the attempts, because the last thing that we want is a successful attempt. Professor asked me to talk about failures. Yeah, no, oh, thank God. All right. Acknowledgements go to the factory for their support and their funding. Professor Noeline, Professor Fred, and Vice Provost Make, thank you so much for the granting opportunity. Washu and Makerere University for the collaboration, the place where I work for the support. My mentorship has been great from Dr. Noeline. She has supported me throughout this study with Dr. Mugisha as well, and I cannot take that for granted. I spent many days in Dr. Noeline's office trying to figure out the best way forward, and eventually it came to this. Taso Masaka for the support, and the study participants cannot be forgotten. Thank you. I'll say one more thing before I leave. It's just a quote. Each one, reach one. Each one, heal one. Thank you.
Thank you, Dr. Raymond. So as he said, each one reach one, each one heal one. I got it. Okay. So our next panelist is Dr. Anita Rinda. She said, okay. Dr. Anita is a psychiatrist who trained from Makerere University in Kampala, Uganda. She has a great passion for child and adolescent mental health research in low resource settings. Her focus lies in neurodevelopmental disorders, including autism spectrum disorder, intellectual disability, and attention deficit and hyperactivity. Beyond research, Dr. Anita provides clinical services for children with neurodevelopmental disorders. And as part of her CHILD-GRF training, Dr. Rinda assessed understanding and retention of HIV information among adolescents with intellectual disability. To further her work, she's currently a fellow on another training grant where she's investigating intellectual disability and associated factors in children with epilepsy. So welcome, Dr.
Good afternoon to you all. I'm very grateful for this opportunity to present my work with the CHILD-GRF. So as it has been introduced, my project looked at an HIV education program for improvement of HIV knowledge among adolescents with intellectual disability in Uganda. Entebbe is a peri-urban region in Uganda. Okay, so for this study, my objective was to assess the impact and the acceptability of an HIV education intervention for adolescents with mild and moderate intellectual disability. And this was a quasi-experimental study with a non-randomly selected control group. So we recruited participants from 2 schools in Entebbe. So one school was the intervention arm, and the other school was the control arm to prevent mixing up. So we recruited adolescents 12 to 17 years who we had assessed and found out that they had either mild to moderate intellectual disability. So we had 30 participants in the intervention arm and 30 in the control arm, who later got the intervention after the study ended. And for the intervention, we designed an HIV education program. So I reviewed literature about existing programs. And then after getting a draft, we discussed it with both the teachers and the representative of people with disability in the region. So this intervention was delivered by their teachers, the special needs teachers, in groups of about 4 to 6 members. And our main outcomes were change in HIV knowledge and attitudes and the acceptability So here I'm just going to present, since I was given about 5 minutes, I'm going to present our main findings. So our main findings was to look at the change in knowledge, HIV knowledge and attitudes from of the participants. So we compared knowledge and attitude scores from baseline to immediately after the intervention. So you see we have the knowledge, we have the intervention arm and the control arm. So I want us to move to the row of the mean difference. So basically you control the mean difference in knowledge and attitudes initially and after the immediately after the intervention. And you see that there's a significant difference in the mean difference, as well as the attitude. So here we're just assessing the change in knowledge. But then we also wanted to see, can these people retain this knowledge? So that's why we pushed to do a further assessment at 3 months after the intervention. And you see that, yes, there may have been a decline in the mean difference, especially for the intervention arm, but still there was a significant difference between the intervention arm and the control arm, showing that our intervention was able to improve the HIV knowledge and attitudes. So what are the implications of this research? So this research has implications for policy and advocacy. Why? Because where this research comes from is that these adolescents are rarely involved in the HIV prevention campaigns, because people think these people are probably asexual or they have abnormal sexuality, or that these people won't understand the knowledge that is given. So now this gives us information to show people that, yes, these people can benefit from HIV prevention campaigns that are specifically designed for them. Secondly, it also helps to reduce stigma. And I thought of stigma in 2 ways. So yes, you can give them knowledge about stigma so that they do not stigmatize other people with HIV. But also, we are reducing the stigma that these people are asexual, they can't learn anything, so don't involve them in the HIV campaigns. Yet they are also at risk of getting HIV. But also, this study helps to show that we can support caregivers and educators to help us provide this knowledge. So this knowledge wasn't given by a health worker, it was given by educators who were, taught, and they were able to teach the students. So the lessons and achievements. So my first lesson was community engagement. So I've always done, prior to this, my research had been in hospital settings, which are quite different. So this was my first research in the community. So I had to go and look for the person in charge of disability in that area, for me to get access, and then I had to find the person responsible for education to get access into the schools, and then I had to work with the teachers to develop the intervention. So this was something that was new for me as someone who always does research in a hospital setting. But I also got a mentorship from both the team at Makerere, from other fellows, but also from the team at CHILD. The other thing, so this is an achievement, grant writing. So I was able to write a few grants, none really NIH, but about 5 grants. And now I think I have a portfolio of failed grants. I managed to get only 1, so 4 of them I failed. But at least it gave me the courage to write something. And then the publication. So prior to joining the program, I had only 1 publication. Now I have 3 publications, with 1 as a first author. And I have submitted work from this study to AIDS Education and Prevention. And I hope to hear from them soon. So next step. So I intend to continue doing work on neurodevelopmental disorders, because this work is lacking in our setting. As I said, I'm doing a D43 on intellectual disability and epilepsy, but also something that I'm very passionate about is development and adaptations of interventions to support caregivers of children with neurodevelopmental disabilities. This was one of the things I applied for funding, but didn't get. And then I also hope to start a PhD this year. So I'm writing a few concepts here and there. Okay, so thank you. So I acknowledge all these people, the mentors, Makere, CHILD, the fellows, and the research team, and NIH, obviously. Thank you.
Congratulations, Dr. Anita. So that's exciting. Our last but not least, panelist is Dr. Violet Nabate. Dr. Nabate is currently a pediatrician at Nakaseke General Hospital in Nakaseke District in central Uganda. She holds a Master's of Medicine in Pediatrics and Child Health from Makerere University. Her research interests are in depression among adolescents living with HIV and how to address this to improve children's well-being, adolescents' well-being. So, welcome.
Good afternoon, everyone. Yeah, I'm very happy to be here and to share a bit of the work that has already been done, supported by CHILD-GRF. I looked at depression among adolescents living with HIV, and this was a hospital-based cross-sectional study that was done in Uganda. I just want to take us a bit through the global picture that was shared much earlier. We have 10 to 20% of adolescents having issues of mental health. And then still looking at the global picture, we have 1.7 million adolescents that are living with HIV. And particularly in sub-Saharan Africa, we have 1.5 million adolescents living with HIV. And coming closer to home in Uganda, of the general population that is living with HIV, 11% of these are adolescents. But we know that there's a relationship between HIV and depression. So that's why I came in to look at this. Previously, I'd worked for around 6 years as a head of an adolescent clinic, taking care of patients with HIV. And I actually realized that depression was part of the issues that were affecting them. And this had a significant impact on their HIV treatment outcomes. So that's why I took this route to delve into trying to find out what exactly happens. More statistics about Uganda. Uganda is ranked among the top 6 countries in Africa with 14 million mental disorder cases. And the rate of depression disorders is noted at 4.6%. But looking further down at depression and anxiety by gender, it's more amongst the females, that's at 5.1%, and then for the males, it's 3.6%. Now, in terms of the study that was done, I did this work at my Center of Excellence for HIV Care, and data collection was done between July and December 2022, where we enrolled 414 participants. We went through the rigorous systems for conducting scientific research, where we had to get different approvals, and all these were done for us to be able finally to do the patient recruitment. And we used questionnaires that were administered to these adolescents following assent and consent, where that was required. We had to abstract some data from their clinic records, but we also looked at depression, stroke depressive symptoms using the Patient Health Questionnaire 9. And that's the way we was able to collect the information that we needed for this particular study. Now, looking at a summary of what we picked out, looking at that pie chart, 33% plus 11 and 13. Overall, looking at the depression scores, for the patients who had depressive symptoms, it was 47%. But looking at depression proper, this came down to 13.8%. So previous researches had been done, and still when they looked at depressive symptoms, the scores were still high. And a case in point is the studies that were done before ARVs became readily available for these children. So the percentage was still above 40. And then we are still looking at a percentage that's still above 40, despite having ARVs on board, which means there's something that has not been done. And previous speakers have talked about integration of mental health services, but this has not happened to scale, much as it's been recommended severally. So that is why we still have that high prevalence. And then, of course, looking at those that scored moderate, moderately severe, and severe, because on the team that was conducting the study, that was me, plus we had a counselor and a psychiatric clinic officer. So these were able to handle these adolescents that were picked out, and then we referred some to the mainstream mild care system. Now, when we went into the different analyses, looking at factors that were associated with depressive symptoms, we had high viral load, poor adherence, and the fact that we had older adolescents. So looking at this, of course, as I talked about the bidirectionality of HIV and depression, it's no wonder that the children or adolescents that had high viral loads were more likely to be depressed, and those that had a poor adherence, because the two impact each other negatively. And then, of course, with older age, the perception around life, perception on body image, why am I taking this medication? It all subjects this adolescent to getting out and trying to figure things out, which might end up causing them mental health problems. And then when we looked at the multivariate, the females were more likely to have depressive symptoms. So again, this has been documented by earlier researchers. In the conclusion and next steps, we note that a lot still needs to be done to reduce the high prevalence of depression, stroke, depressive symptoms now. I am looking at writing a concept on functionizing Listen to Me corners as a safe space for routine screening and management. When you have a high prevalence of depressive symptoms, which is at 47%, high chances that if this has not been attended to, they are going to dip and get the depression diagnosis. But through our interaction with these adolescents, we discovered that their cry out was we need someone to listen to us. We need someone to attend to our non-HIV concerns. And so I am looking at writing this concept to make sure at least we create the Listen to Me corners to be able to save these children from progressing into further depression, and hoping that from some of the talks we had yesterday, the integration of mental health service happens, and that way we can be able to pick these out. So that is it about the work that I have done so far. Thank you.
Thank you so much to all our panelists. Could you please make your way forward to this table? You're going to ask questions, I think. I have two to begin. Yeah, I'll just stand. Also. So to our audience, please prepare your questions. So I'm going to begin with two questions. And these go to Dr. Rachel and Dr. Raymond, because your research focused on suicide and and depression. And also we have talked about integrating mental health services in clinic settings. So could you talk a little bit about for those who screened positive for depression, for severe depression, but also those who had suicidal ideation, how did you handle the after? For Dr. Rachel, even those who did not respond to your question around seeking treatment and counseling. So what did you do with these particular participants?
Thank you. So what we did is that we got our study incorporated into the Baylor system. So we were able to follow up those participants. And because we were looking for those who were able to go to the referral point, so all those that were not able to go were able to track them and did have discussions with the clinical head, because we were not allowed to treat their patients. So we did reach out to the clinical head and extracted the data for her that these particular adolescents are at risk. Yeah, and together with the research assistant, she did reach out to these participants, because as by the system of Baylor, the adolescents are called to be reminded for their review dates. So it was easy to reach out to these particular adolescents since their contacts were there. We had provided them with the list of those that were at risk, and then the clinic did follow up to pick them up.
Thank you.
Yeah.
And Dr. Raymond?
Thank you so much, Dr. Prosi. So considering the sensitivity of the subject, prior to submission for IRB, I had to design a protocol for referral in case such issues came up.
Yeah.
But during interviewer training, we had to go through a brief sensitivity training to be able to identify some of let's say, for lack of better words, symptoms or indicators that may pop up either through the responses that the participants might give, showing that they have chances of ideation, or based on the information that they might have been holding back. The purpose of this was to provide linkage. We're not using the team as counselors, but where the study was being implemented at TASO, I had to bring in the counselors from there. And that was actually a requirement for their capacity building as well. So when we identified cases that could be triggering, we informed those counselors, and that is the point where they started from. This was within the informed consent, so participants knew that this could pop up.
Yeah.
But other than that, if the situation went beyond that, within the same protocol of referral, it went all the way to institutionalization if it was necessary. And at every point, I had a point of contact, and wherever the counselors saw fit, they would be able to refer to the next step and to the next step until the child received all the care that they needed.
Thank you. Yeah. Thank you. Okay, and my next question goes to all of you, and it's around engaging the community. So whether your hospital setting or the institution where you recruited your participants, so how did you work closely with the key stakeholders or the people within that setting to make sure that you're able to conduct your research? And I'll start with Dr. Arinda because she talked a little bit about this.
Okay, so as I said, this was my first time to do research outside a hospital setting. So starting out, and I didn't really know the area when I was. Okay, so when I was starting off, I actually didn't know the area. So someone referred to me one of the, through a friend, someone told me, oh, there's this lady that leads a school for children with special needs. So I approached her and she helped to direct me now to the, we call them the counselor in charge of people with disability in the region. So I reached out to her, I talked to her, I explained my project to her. So that's the point where we started designing the project. So I had, as I said, I'd already initially looked at different programs and come up with a draft. So I had to present this to her and say, okay, this is what I have come up with. And actually, looking through what I had presented, she told me, let's include something on sexual abuse because these children are at risk of sexual abuse. So I had to find a way to incorporate that. But she also connected me to the teachers in one of the schools. So I also worked with them to see what else, how to really change the program. And then they also connected me to the head of education, because we also need their permission for us to be able to work in the schools. So it was, the community really connecting, one person connecting me to the other. But then also, at the end of the day, I wanted the teachers to be the ones to deliver the intervention, because these are children with specific needs in learning. So an ordinary teacher or an ordinary health worker may not be able to teach them. So I was able to work with them to deliver the intervention. So that was my experience with working with the community, and I think it was a fruitful one.
Yeah. Thank you. Dr. Violet.
Thank you very much. For me, I would actually say getting into the community or the hospital where I did this research was pretty easy, because I'd worked with this hospital for about 6 years. And when I went in to introduce the work that I needed to do, they were confident that I knew the problems there, and they really needed the information. They wanted to document the data. So I found it really pretty easy to get incorporated into there, much as I had to go and talk to the administrators about it. They understood what the project was about. And it was really very easy for them to sign the institutional approval for me. And then I was able to do that. Immediately after I finished, I was able to share the results with them, and they took it on quite easily. Yeah.
Okay. I think in my case, I would say it has been I think a privilege to be a part of iChild, because most of the work we do is community based, and prior to implementation of the study, I had an opportunity of engaging with the community at TASO. So there was sort of a prior connection that grew over time, and when I approached them to participate in this study, they were more welcoming. I guess it's an example of using available systems in which we exist to try and achieve maximum utility. So that was of much benefit to me. It could have been harder considering the sensitivity of the topic, because some parents would have said, aren't you trying to get our kids to actually kill themselves? And that trust was built over time. And I'm glad that it eventually paid off when I was rolling out.
Thank you. My community engagement started through my mentor, Dr. Kena, who knew the clinical head at Baylor. So when he made a phone call, when I reached there, it was easy sailing for me. Yeah, and when I reached Baylor, they were grappling with this problem because they were doing targeted screening. Why is this adolescent failing? Let's screen for depression. And as we said, they were not getting the numbers. Yeah, so they were grappling with how to incorporate mental health care into their clinical care. So when I showed up, I'd come to solve their problem, part of it. Yeah, so they were very happy to receive me. And so I worked through with the clinical head, the research director. And so when we finished our study, it was helpful that I was not scared to disseminate my results to them. I didn't have to sugarcoat the numbers, yeah, because they knew they had a problem and we'd come to put some face to the problem and propose a possible solution. Yeah.
Thank you. And I hope that is going to be a practice from that.
I hope so too.
Yeah. And by the way, shout out to all the mentors. You have done a wonderful job. Okay, I'm going to open up for questions from there.
Yes, I'm curious to know how you...
Can you introduce yourself? So
my name
people
is
know.
Flavia Namuonge. I am a PhD student here at the Brown School. My question is more of the ethical bit. I'm curious to know how you assessed comprehension of maybe the consent process as you set out to do your study, given the population that you're working with. Is there like a tool you used since you worked with people that have this intellectual disability? I'm really curious to know how that was handled. Thank you.
Harriet, the next.
Thank you very much. I'm Harriet. And my first question goes to Rachel. Rachel, you talked about a certain percentage that was noted with the mental issues or depression. And then later on, you talked of some that never reached the counseling point. And even those that reached weren't given the message or the package for mental depression. So I just want to know why. Did you discover something that was a bit silent that you haven't presented to us? Why were they given message not related to the condition that you had noted? And then my other question also goes to Dr. Alinda. What was the characteristics of these two schools? Were they government, faith-based, or private, personal-owned schools? That would give us a good comparison for the package that was there. And then kindly, my last question goes to Dr. Nakasuja. Thank you.
Dr. Nakasuja is not on the panel.
Sorry.
Which one?
Doctor from, sorry for that.
Is it Dr. Navate?
Oh, Dr. Navate from Nakaseke. Yes, I'm sorry for that. And thank you very much for the finding that we are able to also relate with the previous researchers. I just wanted to know, as you are reviewing the patient's files, what were you really looking for that would help you address the gap? Thank you.
Let's answer those first.
Let me begin with mine. Why some adolescents went and then the care was not mental health related. So what I have not presented here, because I had only 7 minutes, was that we did collect qualitative data on the adolescents that never accessed care, even when they were referred. And so some of their views were they don't have time. They have come to pick a particular service and they want to go home. And then they don't have money to come back in the middle before the next review to possibly do the mental health care. But then also the other key thing was, how do I go and begin introducing myself to a stranger, to tell them I have come, I don't know, for all these things, the tool sent me to come to you. The adolescents preferred that someone would take them to that room, do the introduction on their behalf. Why have you come? What is it? So a prompt was not enough for the adolescents to seek care. Yeah, and that's why I said that there's need for them to actually do actual linkage besides the increasing the awareness, because some of them did not even know that there were mental health services at the unit. Yeah.
Thank you. Dr. Arin, a question for obtaining consent.
Yes, so I have two questions. Yes, so the first question was about the consent process. Okay, so obviously, so the consent process, we first got consent from their caregivers. So ideally, we get assent from the adolescents. So it's only later that I realized that comprehension is a necessary part, and I hope moving forward, since I'm working with this group, I have to assess comprehension. But what we did to at least see that these adolescents understand what we are going to do. This consent process was obtained by both the research assistant, but also a teacher, because these teachers understand, they better know how to teach these students and things like that. So we had both of them during the consent process. But yes, that's an important thing. And I think there are tools around that help to assess comprehension. So I think moving forward, since I'm still going to work with such a population, I'll be able to use those.
Yeah.
So the second question was about the characteristics of the two schools. So one school was a government school, a government aided school. And then the second school was really an NGO, non-government organization. They get funding from here and there. The children don't really pay any, so that children basically, first of all, in the social demographics, they were similar. I didn't show that table, but there were no statistical difference in the participants. But also the layout of the school, even in the NGO, it was mainly children that come from poorer families. A lot of them do not pay any school dues and depend on aid to support them in the school. The same with the government setting. Really, in the government setting, they pay a negligible amount of money and some comes from the government to support them. Yes.
Thank you so much. Other questions?
Thank you very much.
Oh,
yeah, Harriet asked the question of what exactly we're looking for in the patient files. This study had set out to look at the prevalence and factors associated. So in the literature, there were different factors that we had read about and documented, and some of this information would only be got from the clinic files. For example, looking at the ART regimen these children were taking, looking at their viral load, CD4 counts, their duration on ART, clinical staging, all this had been documented in their clinic records. And so we needed to extract this to be able to find the associations with depression. Thank you.
All right. Thank you. So I saw Jennifer, yes. And
thank you. This goes to Dr. Violet. You talked about the listen to me corner. Do we already have existing infrastructure? Because I heard about the safe spaces for adolescents, but I don't know much about it. So I'm asking, is this something new you are starting, or it is going to be incorporated in the already existing infrastructure in the hospitals? And are you only thinking about Nakaseke or even other places? And given our resources in the clinics there, how is it going to work?
Thank you very much, Jennifer. Okay.
I'm supposed to.
Yes.
This is not a question, it's just a comment that sometimes when we go to do research, we find certain things that are very interesting, but we may not figure out how to report it. Usually the first sentence in many mental health research grants is that mental illnesses are poorly identified and inadequately treated. And I think that's what Dr. Linitwe found, that there was poor identification of mental illnesses in her setting, and then it was also still poorly treated. What do you mean? They were not being identified, and even when you refer the participants, they are still not being taken care of.
Yeah. That's still a huge gap. Yeah. So yes.
Thank you very much. I really want to congratulate my fellow mentees for coming this far. It has been an interesting journey. My question mainly goes to Rachel. I am fresh from the implementation science session, and your innovation is very, very interesting. But I was looking at the feasibility and scalability of Kasai, the Kasai intervention. I think it's really good, and if scaled up to other areas, it will really improve on screening and management of depression among these adolescents. Thank you.
One more for Steph. And then ask
Mine goes to Raymond. I'm sure you expected that. I want to ask, based on your last phrase, each one reach one and each one heal one, or teach one. I want to add teach one. I know that you talked about the awareness, limited awareness about the linkage between mental health and suicide. And I know the study focus was basically on adolescents that are affected, or my HIV and AIDS. How can you have in your recommendations, if they have a component of promoting awareness that is just not limited to this group of adolescents, but also opening it more wider? That is one. And I'm wondering whether you've also addressed your mind to the surveys that are carried out by WHO within the schools. It is kind of like self-assessment that gives data on the state of mental health for students. It's a school survey. It will be also a good source of data for you. I'll get for you the details and then share. Thank you.
Thank you. Thank you. Dr. Violet, do you want to begin with your questions? Who? Oh. Okay, let's add one last one.
Thank you. This has been such a rich discussion. So thank you to all of the panelists. My question was for Dr. Raymond about the adolescents who had suicide ideation. Two questions. One was, are you aware of qualitative research that is meant to elicit from adolescents the types of non-clinical interventions they would be interested in to address mental health? Because I'm thinking about, I know in many settings, I know less about Uganda, but in many settings in the US, addressing mental health issues outside of the clinic includes exercise, support groups, meditation. There are many kind of interventions that might be useful to adolescents. And my second question, follow-ons to that, whether there have been some studies around that in Uganda. Thank you.
Okay. Dr. Violet.
Thank you very much, Jennifer, for your question. Now, in our setting, we know we have had what we call adolescent-friendly corners. They are actually still in existence, but the challenge is because of the integration of the mental health service that has not happened to the scale where we want it to be. These corners are present, but they're just like a sitting arrangement to keep adolescents away from adults. So it's more like a waiting area when adolescents will get out and go and seek their other services. For example, at the place where I did this study, the corner is there. They sit there, and all that happens after that is calling out your name. You go and see the clinician and then move and pick your treatment and go home. So what I'm looking at as the Listen to Me corner is to functionalize that space, make sure we have staff in there to attend to them, to listen to them, engage them, and see how this can help them to reduce the prevalence of depressive symptoms.
Thank you. Dr. Raymond, you had a few questions.
Thank you so much, Dr. Percy. So the first question from Ms. Stella about being able to broaden this prospect of awareness far beyond adolescents and maybe to other populations. I think the best fit for this that I could think of right now is leveraging one of the interventions that we're using called the multiple family groups. The good thing with this intervention is that not only does it address at the clinic level, but it goes as far as addressing the family level. And that, as we know, is the smallest social unit. I believe that if we're able to have families come together and actually open up about some of these issues, that would be a good start of going beyond the adolescents. And for the caretakers to actually understand that this is not your child trying to pretend, but this is an actual crisis that is going on. I think from that point onwards, we'll try to broaden out once the curriculum is developed, probably to health facilities, but also thinking about the community. And when reach goes further, it could be also addressed into schools to be able to get a wider reach. In regard to the surveys by WHO, I think it will be a great resource to me, and I look forward to interacting with you to get that information. Then Melissa asked about if I'm aware of any qualitative research amongst adolescents that looks at a non-clinical approach to to addressing suicide. And at this point, I think that is that's an area of improvement that I can look into. I will not say that I cannot firmly say that I'm aware of any at this point, but that is a resource I can get into to be able to have a better understanding of this. And in the same way, in regards to interventions, I think this will be in the same pipeline. Yeah, that's what I can say for that issue. Thank you.
And by the way, we have Dr. Mugisha, an expert in suicide, so he's back there. I
Yeah.
know he's trying
Mentor.
not to be recognized. Hey. There is the mic.
And possibly the difference is who is doing it. TASO will have the same concept. USAID is promoting the same concept. And they are fragmented, small in nature. We've not looked at the effect size. So there are a lot of efforts, but we've not gotten to the level of developing a national agenda. So every researcher is doing something, give it a nomenclature, and then we wait to see. And that has also been the failure of everything in our HIV strategy. From yesterday, I was hearing about the failures to detect mental illnesses in our hospital settings. And we had a national program where I was ambitiously engaged for 2-3 years, the MH gap. And at one time, we even said, let us put it a little low, the MH gap for children. But then the conversations have not changed. And I was whispering to this gentleman that how I wish we can look at all your recommendations and read discourse analysis and start theorizing what is really the problem. And from that, we can have a national agenda. Otherwise, we are going to get tired and tired. We shall have a Dr. Prose approach, a Mugisha approach, a Nakasuja approach. And then we wait for years and years. The paper that I teach gives me some insights on this. I think we need to get a little more concrete as a group, get back to the health systems. These problems are the same, it seems like. And Raymond is at the tail end. The failures of all these other things. And as Bishop yesterday said, there's something wrong with our family and our traditional systems. And then we get into all these issues. So, Doctor from Nakaseka, I'm not trying to undermine your efforts, but I'm trying to be a little more naughty into the way we do things here in Uganda. We've done a lot. Now I'm tired because I think nothing works. And when I hear a 14 million grant and what, I used to be excited, but I'm no longer excited anymore. So even integration that has been elaborated, it became a sexy concept. Everyone was talking about integration. And still the problems have persisted. So we need to sit down. So I wish we can, Dr. Prose can give us an opportunity where we synthesize and do a discourse analysis of all these things.
Oh, you have everyone in the room.
That we are talking about. And develop a national agenda that is a little different, putting all our recommendations together. Because I think the problems are the
Please
same.
in the chat.
Thank you so much.
Thank you. So my last one, I promise you guys to celebrate the failures. So in closing, I want each one of you to point those out. Starting with Dr. Rachel.
Okay, thank you. I think I have 2 key failures. One was my first submission of my work to the Journal of International AIDS Society, which was rejected. But I had had rejections before, so I just moved on, looked for the next one. Yeah, and then the other rejection was that I still have anxiety over grant applications. So I did talk to Professor Nakasuja that I wanted to just go through that process to relieve my anxiety. So when she had an opportunity, she gave me to try. And of course, it was rejected. But still, I knew I was doing it to gain confidence. So it was not a big hit, but it gave me some kind of grounding, reduced my anxiety a bit. So I should be able to jump in after some time.
I'll say congratulations because you submitted it. So, and that's always the difficult part.
A failure. So I think my most recent failure is grant application. It was a training program. It's called the STES program on cancer epidemiology, and I had set out to. It's the same issue of suicide ideation, and I was trying to look at a stratified approach depending on diagnosis and also extent of disease. It was thrown out. Yeah, it was thrown. It was reviewed, and I got so many comments, and that kind of like it kind of like disappointed me. But the comments is what I used to improve it, and I hope to apply for something else probably in the coming months, and inshallah. Yeah.
Congratulations.
Okay, so my first two failures are similar to theirs. Grant application, as I said, I think I've applied for 5 grants, none NIH, but I only managed to get one, which is also a D43. The others, for some reason, I've applied with like 2 with Prof. Nakasuja as co-PI, but they didn't go through, but at least that was experience.
Yeah.
Then also the manuscript rejection, that has been an issue. And the reason they give me is just, it is not a good fit for this journal. So I have to still look for where it is a good fit.
Yeah.
Then
Trust me, it will find a good home.
yeah. Then the other one was the work-life balance. Last year I got burnt out. Last year I got a typical burnout towards the end of last year. And I realized I was doing a lot. So this year I have set goals on how to manage that so that I don't crash like I did last year.
Yeah. Thank you for sharing. You learned from what happened last year.
Yeah.
So we'll say congratulations.
Right. Yeah, thank you very much. I'll say that I so far do not have outstanding failures because I'm still in the process of concluding my manuscript and writing that and then considering the grants. But through the GRF program and this audience, what I have listened to, I actually realized that taking failure is actually something positive because even people who have been there, who are you looking at and you're like, this mentor of mine, and they're really great in this field, are still getting failures. So who am I at the tail end who is just starting? So that is giving me the comfort that even when that point comes, it shouldn't be something to sink me, but rather to catapult me into continuing it. Thank you.
Yeah, thank you. A big round of applause. So thank you so much for sharing. Congratulations on all your accomplishments and failures.
Thank you.
Please remember we have a ceremony later today for our trainees as they graduate from the program. So be here. What time is it? Yeah. Yes, and then lunch is ready. It's outside, right here. But be back at 2 p.m.
Yeah.
So the ceremony is at 4:45.
All right. Thank you so much.
Congratulations.
Thank you so much.
It is.